Good evening, everyone.
Hello, Dr. Tej.
Please start. Yes, said yes. Parag is saying he start.
Hello, Meena.
Okay,
Yeah, it's
ma'am.
4 o'clock.
Yes.
Yes, ma'am. We are all good to go. Sunita ma'am has joined.
No, start.
Okay.
She will address whenever she joins here.
Okay, fine. Okay. So, respected President of FOXI, Dr. Sunita Tandurwarkar, and Secretary General Dr. Suvarna, as well as the entire FOXI team, the ICOG Chair Dr. Parag Biniwale and Chair-elect Sheila Mane ma'am, Vice Chair Professor Ashok Kumar sir, and Secretary ICOG Sarita Bhalerao. Conveners for today, Dr. Lakshmi Srikhande, past Chair ICOG, Dr. Meena Samant, ICOG Governing Council Member, Dr. Pratibha Singh, Chair of the International Academic Exchange Committee, all dear faculty, speakers, chairperson, moderators, panelists, and my co-conveners for today, Dr. Shrutika Thakkar and Dr. Manan Wu. I extend a warm welcome to all of you. Welcome, friends. Hearts full of Foxy ICOG, which is one big family. Welcome, friends, with the hearts full of glee to Foxy ICOG, one big family, caring, sharing all we know. Together we learn, together we grow. A warm welcome to all of you to this masterclass conducted by ICOG, which is very academically packed program for the next 3 days. And to begin, I would request our backend team to please start off with evoking the gods by a small lamp lighting, virtual lamp lighting. Nilima, can you please do the needful?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Supriya, you need to unmute.
Yeah, sorry. So with that, I thank the backend team and we'll proceed with the inauguration program wherein I would request Dr. Parag Biniwale, the ICOG chair, senior consultant from Pune, to address the gathering and give the welcome address. But before that, I must say these 4 lines about Parag. कि जिनका राम सा व्यवहार और सज्जन का आचार, आई एम श्योर एवरीबडी विल अग्री विथ एवरी सिंगल वर्ड आई से, जिनका राम सा व्यवहार और सज्जन का आचार इनकी अध्यक्षता के रूप में मिला आईसीओजी को उपहार. A big round of applause for our ICOG chair, Dr. Parag Biniwale, very benevolent and academically, extravagantly, accomplished person. Parag sir, we would like your welcome address as the chair of the ICOG.
Thank you, Supriya, for those lovely words and share. It is indeed heartening. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all with another episode of a certificate course. And this time it is going to be on abnormal uterine bleeding, which is one of the most common problem that as we gynecologists and obstetricians face in day-to-day practice. At the outset, let me appreciate the efforts put in by the conveners, Dr. Lakshmi Srikhande, past chair of ICOG, and ably supported by Dr. Meena Sawant, who's a very sincere governing council member, and Dr. Pratibha Singh, who's currently the chairperson of International Academic Exchange Committee. I also thank all the faculty who agreed to be part of it, and I'm happy to say that we already have received over 1,000 registrations for this program. So I'm definitely looking forward to this as a great learning experience. Lakshmi has chosen faculty. Uh, she has practically handpicked the best people to give talks, and of course, there are going to be interesting case-based panel discussions as well. So I'm sure by the end of third day, all our viewers will be enriched with knowledge, and they will be able to help our women who suffer from abnormal uterine bleeding, may it be a young girl or may it be a postmenopausal woman. I think ICOG will do its bit to offer whatever best treatment we can. So thank you very much and best wishes for the program. Please don't forget, for the delegates, you have to attend all 3 days, attempt all 3 post-tests, and secure more than 50% mark to receive certificate from ICOG. Of course, you have to be a member of FOXY to receive a certificate. And I also welcome Dr. Sunita Tandurwadkar.
Yes.
Sunita, welcome to this program, and we were waiting for you. And it's been quite some time that we've always missed you on ICOG programs because you make it a point to attend it. May I request you to say a few words, please?
Hi, Parag. Thank you so much. Initial, I think 4 months, I ensured that every meeting I will be joining you all because it's not that Foxy president or ICOG chairperson. It is the love of for these programs of yours. They always fetch up so much huge attention. They are so academic, and I get to see all my friends across the country or a globe in our ICOG program. So I always love. Unfortunately, as you enter in a Foxy, more and more every 15 minutes you have one national or international other meetings, and unfortunately, I just could not join. But thank you so much. And to these certificate courses which you are bringing in, getting so much attention, value addition. I was having just one suggestion. Do we have some ICOG credit points to it?
Yes, of course.
Yes.
10 credit points for the program.
Superb, superb. So, because I was not knowing, it was not so well highlighted. That brings too much of attention or a attraction towards it. And ICOG's always was doing great job. I think past ICOG chairpersons, I still remember working with Anklesari and all. Parag, you, me, both we have worked and they have made it. But Parag, this year, you have really taken to the different level. I know Lakshmi will look at me with the glasses so much.
No, I'm happy
But
for
that's
you.
how everyone works. And I'm sure the next chairperson will come out with another brilliant
Yes.
ideas. Sarita, and your combination is fantastic, the way ICOG is flying. And thank you so much for always asking me to join and reminding me repeatedly. Where is Sarita? I can't see her, but she ensures that I join, though I don't see her. Supriya, thank you for your calls. When I'm operating, I just could not take it. Thank you so much. Thank you,
Sunita.
everyone.
Thank you for being here with us.
Thank you, ma'am. That was our Foxy president for you. And madam, I cannot let you escape without saying these 4 lines for you, especially for your, stature. डर मुझे भी लगा फासला देखकर, पर मैं बढ़ती गई रास्ता देखकर. डर मुझे भी लगा फासला देखकर, पर मैं बढ़ती गई रास्ता देखकर, खुद ब खुद नजदीक आ गई मंजिल. खुद ब खुद नजदीक आ गई मंजिल, मेरी मेहनत मेरा हौसला देखकर. So that's our Sunita ma'am for us. Thank you so much, ma'am, for joining us and giving those pearls of wisdom. And now may I invite the convener for today, past ICOG chair,
Sarita?
Dr. Sikande madam. Sarita, I cannot locate madam.
Okay.
Sarita,
Okay.
Suvarna, I don't think they have joined.
Okay.
If they come in later, we'll ask them to address us.
Okay. Okay.
Meanwhile, I'll request our immediate past ICOG chair, Dr. Lakshmi Shrikande, to please give an overview of today's CME, following which we will hand over to Dr. Shrutika Thakkar and Dr. Manan Boop for the scientific session.
Thank you. Thank you so much, Supriya. Good evening and a very warm welcome to all of you. It gives me immense pleasure, friends, to initiate this 3-day academic journey on abnormal uterine bleeding. As Dr. Parag has already said, this topic is integral to our day-to-day gynecological practice. As someone who has crafted this course from concept to content, my vision was to ensure that it reflects the challenges we face in real life clinical settings. The aim was not just to impart knowledge, but to create clarity, encourage critical thinking, and spark confidence in managing AUB across its varied presentations. Each day of this course has a purpose. Today, we lay the foundation with the basics of diagnosis and classification. Tomorrow, we will be delving into management. And on day 3, we will explore the nuances of treatment in special situations. Every topic and faculty member has been carefully selected to enrich this learning experience. I thank our excellent faculty and all of you for joining with such eagerness. I also place on record my sincere thanks to Parag and Sarita for the opportunity to be convener for this course. And I also would like to extend my thanks to my co-conveners, Dr. Meena Samant and Dr. Pratibha Singh, for actively helping me in crafting this course. Let's make this a meaningful and inspiring academic journey. Thank you, and let the learning begin as Nilima is showing the slide. Today we will be discussing, Nilima, I can't see, just a minute. Today we are discussing the basics, that is diagnosis and evaluation. I am not going to read the topics and the faculty name. I am sure you all have gone through it. So now, Supriya, please invite the chairpersons for this first session and let the learning begin.
Thank you so much, ma'am. And I'll now hand over to Dr. Shrutika and Dr. Manan to continue the scientific session.
A hearty good evening to all the faculty and dignitaries present. I would like to invite Dr. Ajay Bane sir, who's been Vice President of FOXI and Second Joint Secretary amongst, as the chairperson for the next session. We also have with us Dr. Datta Parandikar sir, who has been the past president of Thane OBGY Society and a consultant obstetrician and gynecologist and endoscopist in Thane for more than past 30 years. And Dr. Nalini Bagul ma'am, who is the director of Dr. Bagul Hospital and Nashik Fertility Center. And she's been organizing person of AMOX and past president of Nashik OBGY Society. I hand over to the chairpersons to please continue with the session, first session.
Datta, if you are here, please go ahead, as Dr. Ajay Mane is not able to join. He is not well. Datta?
I think Nalini can introduce.
Nalini, please.
Yeah. So the first speaker is Dr. Ram Prasad De, who is editor-in-chief of Indian Journal of Perinatology and Reproductive Biology. Yeah. And he is the National Vice President-elect ISOPAC from 2026 to 2027, National Corresponding Editor of Jogi, and he was a Vice President ISOPAC Kolkata. And
thank you, madam. Thank you.
He has many awards and many publications into his on his name. And
thank you.
Over to you, sir. Day, sir.
Yes, thank you.
Yeah.
Yes. Am I audible?
Yes.
Yes. So I can go to slide sharing. Yes.
Yes, please.
Yes.
Is it visible?
Yes. Make it PowerPoint slideshow.
Yes, slideshow. Yes.
Yes.
Just. Yes. Hope it is okay.
Yes. Great.
Yes. Good evening, everybody. Respected all, respected dignitaries in the dais. It is my privilege and honor. I must thanks and express my sincere gratitude to the ICOG office bearer, particularly the current ICOG chair, Dr. Parag Biniwala, and also the immediate first chair, Dr. Lakshmi Madam, for inviting me. And also definitely the Foxy president and secretary who was just addressed president. It is my privilege and honor to be here I am going to talk on the overview of abnormal uterine bleeding as an opening batsman. In the last coming 3 days, all of you have the discussion with the abnormal uterine bleeding. I just want to highlight my topic will discuss what is the prevalence of this abnormal uterine bleeding, what is actually abnormal uterine bleeding, what actually previously it was before this abnormal uterine bleeding, what we terminology used earlier, and how 2018 FIGO comes with this idea of abnormal uterine bleeding. If you look at the abnormal uterine bleeding, it is worldwide prevalence of abnormal uterine bleeding, particularly in the reproductive age group, is 3% to 30%. Why it is? Because the before the abnormal uterine bleeding stamped as abnormal, actually most of the abnormal bleeding considered it is the heavy menstrual bleeding as abnormal uterine bleeding. It depends upon the country to country, age, parity, and also the reproductive life. Though it mostly affecting the women in the extremes of the reproductive life, that is in the 5th decade or in the adolescence, but it can happen in across the age group. If we go way back to WHO survey in 1992, WHO point that is the dysfunctional, that time it was dysfunctional uterine bleeding, that the heavy menstrual bleeding occurs in any woman, and 19%, that is the every 5th woman is suffering from the excessive menstrual bleeding. Unfortunately, one of these every 5th man eventually undergo hysterectomy. So that is what the sad story, that how this heavy menstrual bleeding or abnormal menstrual bleeding land up into the simple problem, land up into the major surgical intervention. So that is this is the story, his first story, what will happening, because there is a definition, terminology, and the etiology is not clear to all. Approximately 1/3 of the women affected at the same time in their life. Many of the published data actually means that is the abnormal uterine bleeding actually is the heavy menstrual bleeding, but it is not like that. It has other different 3 component also, out of which one is the heavy. Out of the 4 component, one is the heavy menstrual bleeding. Whether the other, if you conclude the other irregularity of menstruals, it is goes prevalence as high as 35%. The available incidence suggests the affected women do not sometimes seek medical care because they do not have, even the healthcare provider do not have the idea what does it mean by regular cycle, what is the regularity cycle, what is the frequency of cycle. So either they overtreat or undertreat the patient. This is the mainstay for the severe disruption of the work. Yes, sometimes it is not actually, does not directly cause mortality, but definitely it affects the quality of life and increase the morbidity. Another thing is the abnormal uterine bleeding. The patient is suffering from anemia, and that patient to become pregnant. This is also, if you all already know that NFHS data is published in India, the anemia and pregnancy incidence is 53%. If you go the same age group patients, the anemia is also 57%. So the anemia in pregnancy, it is not a problem. The anemia itself is a problem in the reproductive age group, and that is actually sometimes exaggerated by the abnormal uterine bleeding, and also presented with the iron deficiency anemia mostly. So with this idea, the 2011, we have already 15 years has been already passed. The FIGO actually set up a clinical recommendation with informing and guiding what do you mean by abnormal uterine bleeding. In 2000, if you go back to the 2011 publications of the FIGO terminology and definitions, there are 2 components. One was terminology and definition, that's the FIGO AUB system 1, and another is the classification, what we are using now, PALM-COEIN classification, that is the system 2. It is important that the clinician recognize both these, must be accustomed with this, and mostly these are the non-gestational AUB. That is abnormal related bleeding. Actually, the pregnancy related bleeding is excluded. And what are the other thing also here is excluded, that there may be some sort of genital tract bleeding out of due to urinary tract gastrointestinal bleeding, that is may actually not come from the uterus. Sometimes it may misleading to term as a abnormal uterine bleeding. These are the FIGO 2011 system, how this abnormal, normal, or what do you mean by normal and abnormal uterine bleeding? The normalcy means there will be a normal frequency, regularity, duration, and volume. These are the 4 criteria, depending upon which we can stamp is a later on stamp is a case of abnormal uterine bleeding. There is another terminology also, it is not nowadays used, that intermenstrual bleeding, which is not actually included into the, it is included as a spotting. These are the another thing also which we can go by the 2018 new definition. What are the things is included? There is another thing you also acute versus chronic non-gestational abnormal uterine bleeding. What is that? These are actually what I am telling. These are the history behind this 2018 figures terminology and definition. Originally, the chronic non-gestational have been reportedly defined as there is abnormal excessive duration progressive bleeding more than 6 months. And if acute, on the other hand, defined as episode of heavy bleeding, which actually compromise the patient's quality of life, and the bleeding is so important that patient do not have the day-to-day activity. This acute on heavy bleeding is that in a background of chronic abnormal bleeding, sometimes may present with the heavy bleeding is called that. But these are the things actually now because to formation of this 2018 guidelines. So FIGO AUB system actually based on 6 years of analysis. It is a not a just 2018 definition comes all of a sudden. It starts from the 2011 to 2018, 6 years analysis, discussion, debate, and since the original publication. I have already told that the system 1 is the terminology and definition, and system 2 is the PALM-COEIN, the etiological, and subsequently they publish the what will be the management protocol, which will be discussed thoroughly in the coming 3 days. So, as for the 2018 definition, what is abnormal uterine bleeding? Is a broad spectrum irregularity of the menstruation rate. The irregularity happens in the frequency, duration, and volumes of the cycle. This is the 4th thing, that is the regularity. There is the one thing is frequency, one is the regularity, one is the duration of bleeding phase, and other is the how much the bleeding. A normal menstrual cycle, which was previously cost 21 to 35 days, now in figure it is a 24 to 38 days. Anything beyond that, we should call as a abnormal. Variation of this any 4 meter, actually 4 parameters should be constituted of the abnormal phase. Any of these, it affects, if you consider this definition, it actually affects to 10 to 30% of the reported age group, but the prevalence will be as high as 50% if we consider take it into the perimenopausal woman. These are the old few definition which sometimes may use by gynecologists may leak in confusion. That is why if you go, this is the oligomenorrhea, that means the cycle length more than 35 days. Polymenorrhea, the frequent cycle less than 21 days. Amenorrhea, absence of menstruation for 6 consecutive cycle. Menorrhagia, that is excessive menstrual bleeding, which is called actually heavy flow. Metrorrhagia, the intermenstrual bleeding. Polymenorrhea and metromenorrhagia. These actually now no more are existence. So better to avoid all this terminology when are seeing these patients. There is another terminology, all of you are few years ago, before the 2011, the dysfunctional uterine bleeding. Even our postgraduate also doing the thesis also in the dysfunctional uterine bleeding, etiopathology, etiopathogenesis management or histoscopic evaluation, all these things. Now, what is this? Actually, what is AUB and what is DUB, and what is the place of DUB in the FIGO's AUB classification? Dysfunctional bleeding of thin where there is no demonstrable organic cause, a diagnosis exclusion. This is the age-old teaching or age-old practicing we are doing, where there is no such actual exclusion. And this etiology was prevalence was as many the 10%, and the 50% near menopause, 20% in the adolescence, and 30% in the reproductive age group. Actually, we broadly classify as anovulatory and ovulatory DUB, and we also prescribe some in the depending on the which is the some of the drugs which actually control the bleeding. But thing is that if we go through this abnormal uterine bleeding, basically the DUB actually the AUB-O or AUB-E. That is that there is no such structural abnormality. There is no such thing is available. It is only basically the endometrial pathology or anovulatory abnormal uterine bleeding. This is actually the new FIGO designation, all of you award 2018. Just I am reminding you for this course, certificate course, what is one is frequency. Frequency should be regularly, frequently, that is the each cycle should be in between 24 to 38 days. Then coming to the duration of bleeding to 2 to 9 days, anything beyond 9 days to be considered of the excessive duration. Now coming to the regularity. Regularity means that it is the common in the reproductive age group with the hormonal change of follicular and secretory phase. The every cycle does not occurs in every woman in the exactly 28 days plus minus 2 to 3. But when is called the cycle is not regularity, if the shortest cycle and longest cycle is more than 8 to 10 days. That means some patients have a cycle of less than 10 days and another cycle of more than 35 days. then you can consider as a irregularity is not maintained. So as for the new figure definition of 2018, the any abnormality, whether it's a form of frequency, duration, regularity, and definitely amount of bleeding, which is more than 80 ml, is to be considered as a abnormal uterine bleeding. Another terminology, most of the gynecologists sometimes why there is a difference in the prevalence 3% to 30%. Somebody thinks that only the heavy menstrual bleeding is actually the abnormality, but it is not that. Heavy menstrual bleeding actually the one component out of these 4 component of AUB. Heavy menstrual bleeding is actually patient may comes with how can we know the patient is suffering from heavy menstrual bleeding? One is the subjective assessment, one is the objectively demonstrated. Subjective assessment means the patient herself, the woman herself telling that what number of pads is using, that is now increasing in number. So you have to frequently change is that process. Objectively, which is qualified as if the patient, woman needs 1 pad have to change more in every 3 hours, then he has heavy menstrual bleeding. Or if you for the hemoglobin is gradually falling, or better assessment, though it is not practically possible in clinical practice, is the pictorial blood assessment chart. This is the chart. Everyone is actually know this. The chart has the pads, how much it is soaked, whether the tamponade is used, whether the clot size small or large, and any other the flooding the bed sheet is more than plus. Then if the score is more than 100 points, it increase heavy menstrual bleeding of that particular cycle. So with this, all these things, figures, pump classification, which will be discussed my next speaker in the subsequent, the PALM-COEIN classification, I do not have the scope to discuss, but just overview, everybody knows the PALM-COEIN classification AUB. It includes actually structural, non-structural, benign and malignant gynecological problem. Everyone knows the PALM is the structural component, polyp, adenomyosis, leiomyoma, and malignancy hyperplasia. There is another thing is the COEIN part is the coagulopathy, ovulatory dysfunction, endometrial etiology, iatrogenic not. What was actually the new difference? I think my next speaker will subsequently discuss, so I am not going to the detail. So to conclude that abnormal uterine bleeding is a common among women worldwide. It may suffer, the prevalence is so high that every 5th or every 3rd woman, even in some country or some region, suffers from abnormal uterine bleeding. A detailed history is important first step in evaluating a woman who presented with the abnormal uterine bleeding. Try to elicit the history, the 4 component, frequency, regularity, volume of blood, and also the how much the duration of bleeding. PALM-COEIN classification is the acronym which currently used for the every diagnosis should be stamped as a AUBP or AUBL or AUBO. Otherwise, nobody can understand what is the etiology of this AUB. And the treatment depends upon this. Definitely, some of the treatment is stoppage of bleeding, improvement of hemoglobin, improvement of general condition, and subsequently, depending upon the etiology, treatment is medical, minimal invasive surgery, and surgery. I do not have the scope for discussion. The next subsequently it will be discussed. Treatment based on the etiology, patient's age, parity, fertility, and associated medical comorbidity, because some of the drug may be of contraindication to the patient, may not continue for long-term medical therapy. One thing we are treating the abnormal uterine bleeding, it may also a cause of anemia, considering in our country where the prevalence of anemia in non-pregnant women itself is more than 50%. And also in the pregnant woman, if the patient have a already pre-existing abnormal uterine bleeding and patient conceive, says patient has this anemia may be a direct or indirectly increase the mortality morbidity of pregnant women and increase the maternal death of our country. Thank you. Thank you, everybody. One session for your patience hearing. Thank you.
Thank
Yes.
you so for the wonderful talk.
Yes. Should I stop sharing? Yes.
Yes, sir. Yes.
Yes, sir. Please stop your screen sharing. Yeah.
Yes, I have stopped.
I would like to acknowledge the presence of Secretary General of POXI, Dr. Suvarna Kadalkar ma'am in amidst us. At the same time,
yeah, invite her to give her address. Dr.
I would like to invite Dr. Suvarna Kadalkar ma'am to please share a few words with us.
Suvarna, please.
Yes, I am.
Yeah.
Just give me a minute. I'm in the car.
Yeah, now I can see.
Yeah. Sorry. Yeah, so at the outset, I really want to thank the whole ICOG team led by Dr. Parag Biniwale, Dr. Sarita Bhalerao, and Dr. Sheila Mane, who is organizing under presidentship of our president, Dr. Sunita Tandulwadkar, and ably assisted by Dr. Professor Ashok Kumar. Lakshmi, Meena, and Pratibha, all three of them are very hardworking. I've been observing their work since very, very long time. I think Meena is very academically and research oriented. I've had papers together. Pratibha has been also working very hard, and Lakshmi, you have been the past chairperson of ICOG. So I'm sure you have excellent. Overview of how ICOG works. And so I think you are the right person to convene this program. And various speakers that you have chosen are really expert in their own fields. And I'm sure it is going to be a very, very good learning exercise for all of you. And it being a certificate course, I'm sure at the end of it, you will get some, I think, FAQs or some scoring. Yeah. So with that,
MCQs, yes.
MCQs you will get, and then with that you will assess your own, assess your own learning that you had during this course. And abnormal uterine bleeding is something which we see daily, and in our practice. But we really every day there are some new advances in the way we treat them medically, where the way we treat them, various procedures, surgical procedures, or the intrauterine, this Mirena, and there are so many newer devices that we have invented. Now, hysterectomy purely for AUB is a rare incidence, and we have to make sure that we save the uterus as much as possible. Whenever there is a abnormal uterine bleeding, try to use the conservative ways in benign pathologies. Definitely, it will go a long way in maintaining the women's health till menopause, as long as the ovaries are in place, uterus is in place, which also helps maintaining ovarian blood supply. The long-term health of women will be definitely maintained, because it is beneficial for the lipids. It is beneficial for the cardiometabolic risk. So we have quite often observed that for early young girls, or I'm not girls but young women who undergo hysterectomy at 40, 42, 45, they lose the ovarian blood supply soon, in within 2 to 3 years. So at age of 43, 45, they have hormonal menopause, and then the body starts showing all the different comorbidities which would have otherwise occurred later at stage. So I wish you all the very best for this particular certificate course, and I hope it's a grand success. I can see the fantastic attendance of 420 people already logged in. So once again, all the very best. Thank you.
Thank you so much, ma'am, for kind words and words of encouragement. I would like to call Dr. Datta Panandekar sir to introduce our next speaker.
Datta, are you here? Datta?
Yeah, I'm there.
Yeah, please.
Can you hear me?
Yes, Datta.
Yeah. So first of all, thank you, Dr. Lakshmi Shrikande, and all the office bearers of ICG, Dr. Parag, for giving me this chance to chair this session. Our next speaker is Dr. Asha Jain. She has been the director of the SMSA hospital at Raipur. She has had multiple posts, being the chairperson of the FOXY FDM MSc committee, president of the Raipur Menopause Society, and the executive of CGISR. Her interests are preventive oncology and colposcopy, along with fetal medicine and obstetric and gynec ultrasound. Uh, she she uh, uh, she does ultrasound and colposcopy training, and I invite Dr. Asha Jain to take the next lecture.
Thank you, Datta sir. Can you see my screen?
Yes, ma'am, it's visible.
Yes.
Okay. So, namaskar. I would like to thank Dr. Lakshmi for inviting me to give this talk. And I also thank all the FOXY and ICOG shareholders for giving me this opportunity. Also, all the delegates who have joined in and my co-faculty, thank you so much. I hope I'm able to do justice in the time that I'm given. It's showing only 12 minutes.
Yes, ma'am. The time apart from that is for discussion as well as for chairperson's introduction and everything.
Okay. So Dr. Ram Prasad Dey sir has made my task much, much easier. He has introduced the PALM-COEIN classification a little. And it's something, these are the two basic papers from which I have taken these articles. All the information that I have has come from these two papers. So why was this PALM-COEIN needed? It was needed because just like the Delphi consensus came in, at the end of this lecture, you should be able to define PALM-COEIN key terms, show how to code real cases, and highlight clinical and research utility. Why did we need? The Delphi consensus came in. They tried to get in the Bethesda classification. They tried to get a classification system for fetal medicine. They also tried it for AUB. All because in different areas of the world, people say the same words for the same conditions so that real scientific knowledge can be exchanged. Now, the old terms, Dr. Day said a lot of terms. He didn't say hypermenorrhea and hypomenorrhea. That was also a term that was included. And it ultimately made everything inconsistent. Now, what we have, and therefore, there was a hindering of audits and research comparability. If you're going to compare your literature and the cases, you don't know what is actually meaning. And in 2011, the FIGO working group created the Delphi consensus for AUB. So AUB means abnormal uterine bleeding. It can be chronic versus acute. It includes intermenstrual bleeding. A normal menstruation is 24 to 38 days. The duration is 4.5 to 8 days, which is the 5th and the 95th centile of normal. So any deviation beyond this is considered abnormal. This is the PALM and the COEIN, and it's polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia, which are structural. And then there are functional, which is the coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. You'll be wondering why endometrial is included here. Because when you can't see an abnormality on ultrasound or MRI, but the function is not normal, it is included in this right side column. What is the beauty of the system? That whatever the cause, it has to come in one of this. A polyp as defined by ultrasound or hysteroscopy, adenomyosis by ultrasound or MRI, leiomyoma with mapping, ultrasound and if needed MRI, malignancy with histopathology correlation, ultrasound, MRI, surgical correlation, a coagulopathy with the previous history, ovulatory dysfunction, you can see PCOS, or you can see other signs of anovulation, a very thick endometrium. Endometrial causes include tuberculosis. They include endometrial resistance, where there is a biochemical change in the function of the endometrium. Iatrogenic, maybe because of an IUCD. And what is not otherwise classified, that means you may have AV fistulas, malformations in the endometrium, and these are. So how is an endometrial polyp classified? It's mostly benign. Its diagnosis is by ultrasound and by hysteroscopy. But for the classification system, for AUB-P, no size subclass is there in the base code. So a small polyp, a large polyp, each will be classified the same as AUB-P. What about adenomyosis? This is an imaging-based diagnosis. TBS is acceptable. Diffuse versus focal lesions, and it can be associated with AUB and dysmenorrhea. Classification, AUB-A. What are the sonographic findings that you are taking? Diffuse heterogeneous myometrial echogenicity includes striations and indistinct endomyometrial junction, anechoic lacunae cyst, focal abnormal myometrial ecotexture, indistinct borders, globular or asymmetric uterus unrelated to leiomyomata. So these are the 4 features. Color Doppler and B mode both can help you identify. Then you have leiomyoma. It can be primary, or primary division is presence or absence. So you will write L1 or L0. Secondary makes it submucous versus other. So submucous, you will write SM, other is O. And then tertiary is 0 to 8, which is the Wamstick or ISGE classification, which we all know. So you will have the primary absent or present, secondary submucosal or other, and then these are the tertiary, depending on the mucosa or the serosa, what is the percentage that is invaded. So this is the complete classification, and how we are going to implement it is what I'm going to tell you. So when you are describing it, there is a particular method that you have to describe, the PALM-COEIN classification. Malignancy and hyperplasia always have to be ruled out. Use FIGO WHO staging separately, include cervical, endometrial, and sarcomas as well. So these are the various pictures of endometrial carcinoma, where you can see that, from the lower edge, whether it's coming up to the cervix, how much of the myometrium is invaded, whether there is a midline visible, what is the tumor-free margin, what is the vasculature, what is the vascular pattern. So you will do a uterine evaluation and you'll do a separate evaluation. So uterine evaluation for enhanced risk of hyperplasia or neoplasia or a structural anomaly, and then take it from there. And when you're describing, it will be AUB, L, submucous, AUB, P, AUB, A, depending on what all you have. You have to describe each one. And then there are the COEIN. This COEIN is, which is non-structural. So in 13%, you would have coagulopathy. You have to screen by the history. Ovulatory dysfunction, PCOS, thyroid, extremes of reproductive life, primary endometrial, local hemostasis, iatrogenic, hormones, IUCD, anticoagulants, and not yet classified AVMS myometrial hypertrophy. So this is the history that you have to take, and always non-structural history is extremely important. Then from symptom to code, you've seen the symptoms, you've taken the history. Now you have to write it in a code. So you need a focus history and examination, labs, imaging, assign the PALM-COEIN codes, and then plan the targeted therapy. So this is what you're going to take in a history: menstrual, symptoms of anemia, sexual reproductive history, associated symptoms, systemic, weight change, coagulopathy, PCOS, drug history, family history, impact of symptoms, smoking, and occupation, and then basic observations of BP, BMI, pallor, thyroid, bruising, Cushing syndrome, hyperandrogenism, any palpable pelvic mass, and then a complete examination, hemoglobin, ferritin, ultrasound, MRI, hysteroscopy. So this is your history, examination, and investigation detail. Chronic AUB has to be more than 3 months. It can be 6 months. Duration, volume, frequency, unpredictability. If it is not there, it's not chronic AUB. If yes, Then you take a structured history, do a physical examination, and then order investigations, as I've already told you. Now, how to code? For everything, PALM and COEIN, you have to write absent 0, present 1, and query not yet assessed. One patient may have multiple categories. Example is P1, A0, LSM1, MOCO, O1, E0. So it's basically, you write it here. As you can see, it's the complete PALM-COEIN is written here. And each thing is given a mark. So there is no polyp, so P0. There's no adenomyosis, so A0. There is a submucous fibroid, so L1SM is there. In this one, there is adenomyosis, so that is there, but everything else has been assigned 0. And when there are multiple, you will mark them multiple. That is how they have to be put into list, because once you have this entire list, you have a complete diagnosis of what is wrong with the patient. You can have a 52-year-old lady, 32 years, heavy menstrual bleeding. She has a 2 centimeter submucous fibroid, also has easy bruising and epistaxis. So how would you code her? You would have to code her iatrogenic versus endometrial overlap. So polyps, adenomyosis, there are many gray zones. In the past case, as I told you, you would have 2 things added in her report, as I had showed you before. What are the gray zones? Iatrogenic versus endometrial overlap. We do not have sub-classification for polyps and adenomyosis. And then FIGO is updating this every single day. So what is the take-home message? PALM is structural, COEIN is non-structural. Code every applicable category. Use in clinic notes, research, and audits for better results. So these are the references. Thank you so much.
Thank you so much, ma'am, for a wonderful, concise, and precise talk on PALM-COEIN. If there are any questions, I would request the audience members to please post them in the chat box. I would hand over for further to Dr. Shrutika Thakkar to carry on with the scientific session.
Sorry, I was mute. Asha. Hello.
Yes, ma'am.
There is one question. Quickly, you can answer whether congenital abnormalities come in N.
Yes, ma'am. Answering.
Yeah. Please invite Dr. Arun. Yeah.
Not being allowed to unmute, that is why I was not able to speak.
Shrutika, just a minute. Who is introducing Dr. Arun? Datta?
Yeah, I can introduce.
Please go ahead. Yeah.
Okay, so our next speaker is Dr. Arun Barua. He is a consultant at Apollo Fertility and Apollo Hospitals in Guwahati, chairperson of the Northeast IAG, founder chairperson of Northeast ISAR, past president of the Dibrugarh OBGY Society, senior vice president IMA Assam State Branch. He is a peer reviewer of Journal of OBGY Societies of India, has had many index articles in index journals and chapters in textbooks and recent advances. Welcome, Dr. Arun Barua, and please go ahead with your lecture. Thank you.
Hello, Arun.
मॅम जॉईन नाही झाले आता झाले होते पण आता नाही दिसत
I just now saw him because they always have net
Yes.
problem. He's logging in from Guwahati.
Yes. He was seen just now, actually.
Yeah, I saw him just now.
Actually, ma'am, there is a heavy rain going on in the northeast, even in Jharkhand. So probably that might be the reason.
Because he logged out. So I think we can have Manan. Till then, you can introduce Shruti. You have joined now. Shruti, please introduce the chairpersons of the next session by then. Shruti. Shrutika. I just not. Shrutika, unmute. Manan, by that time, you please introduce the chairpersons of the next session.
Yes,
And
ma'am. I'll
if
just
Arun
introduce the
logs in, we
chairperson.
can have his talk. Otherwise, we can start with the session 2. Yeah.
Yes, ma'am.
Yeah. Just introduce everyone briefly. Yeah.
Yes. I would like to introduce the chairpersons for the session 2. We have with us Dr. Ashok Kumar Padi, who is an associate professor in gynec-oncology, and he's had a fellowship in advanced and robotic surgery from Roosevelt Park in USA. He's practicing at Cuttack, Odisha. We also have with us Dr. Ritu Khanna ma'am from Varanasi. She has been a chairperson of Foxy Food and Drug and Medico-Surgical Equipment Committee in the 2021 to 24. She's a fertility specialist and endoscopic surgeon. We also have Dr. Shashibala Bhosle. She is from Gwalior and she's been a national coordinator for the International Academic Exchange Committee.
Yeah. So I think they can invite the first speaker of the session 2, please.
I would like,
Yeah, Shrutika, please conduct the session 2.
Yes, ma'am. So I would like to invite Dr. Atul Ganatra.
No.
Ruchika ma'am is.
Yes, I am there.
Ruchika, Dr. Ruchika Garg.
So
let me
shall I
invite
introduce?
Garg, who is the professor of Department of OBGY at SN Medical College, Agra, India. She's also the executive editor of Journal of Suffolk, and she's the editor-in-chief of Journal of Midlife Health, national chairperson of Rural Committee, ISOPARC, and president of Agra Menopause Society. And as we can see, she has been an editor of multiple books. So she's a thorough academician, and it is wonderful to have Dr. Ruchika here. Welcome, Dr. Ruchika.
Thank you. Thank you, Lakshmi ma'am. Thank you, Parag sir, for giving me this opportunity.
Dr. Arun Barua has joined.
Arun, are you comfortable? Hello, Arun? Let's Ruchika finish her talk, then we will invite Arun. Ruchika, you please complete your talk. Yeah.
Done.
Ruchika, please share your screen.
Yeah. Yes, ma'am. It is there only.
I understand. And I'm so happy that there are so many questions for Dr. Asha Jain on PALM-COEIN classification, which is the basic of understanding AUB. And Asha is also very patient. She is answering all the questions. I appreciate Asha.
Ma'am, while we are waiting for...
No, but just a minute, I am doing.
Okay.
वाली PPT
Otherwise, we'll take one question while we are waiting.
अच्छा हाँ downloads में कर
No, yeah, Ruchika has share. Yes.
Yeah.
Hota hai aisa.
So,
Asha, there are still questions for you. Please answer in the chat box. Yeah.
Yes, ma'am, answering.
Yeah.
Answering.
Yeah.
I'm
Thank
still
you.
here.
Thank you.
Dr. Asha Jain madam has made my talk very easy. And so my topic is today about history taking an examination, which is a very important part of evaluation of a case of abnormal uterine bleeding. So we know that 1/3 of the women sometime in their life.
Ruchika, we can't see your PPT
screen.
is not visible. We can see only screen, computer screen.
You have to change the window that you've shared.
Solid
You have to select desktop. When you do screen sharing, a desktop comes, you will have to select that as an icon.
She is very tech savvy person, I think.
What's the problem? Can you see my screen?
So, ma'am,
we can see only your window, computer screen, not your PPT.
Ruchika ma'am, stop screen sharing and again do the sharing again. That time
Different has been shared. Another thing has been shared.
Choose the desktop option.
Yes. Now it is coming. Yes. Fantastic.
Now it is okay.
Make it slideshow. Yes.
Yeah. So we know that 1/3 of women in some time in their life are affected by abnormal uterine bleeding. It disrupts their work, productivity, and moreover, it leads to anemia, leading to increased maternal mortality and morbidity. So we know that the FIGO in 2023 has revised its terminology based on the evidence-based clinical guidelines. Like frequency, now 24 to 38 days is the normal menstrual cycle period. Less than 24 days or more than 38 days is frequent or infrequent periods. And the duration of flow, if it is more than 8 days, it is prolonged. And if the duration of flow is less than 8 days, it's normal. Likewise, if the length of cycle, the shortest to the longest cycle is less than 9 days, then it is normal. And above 9 days, cycle variability is abnormal. Flow has been divided into heavy, normal, or light, and then they have introduced postcoital bleeding, intermenstrual bleeding, and unscheduled bleeding while on hormonal medications. So the importance of history we all know from our postgraduate days, that many things we can know from the history itself. So we know that we have to see the cycle length, the duration of bleeding, what is the estimated blood loss. So from the pictorial blood assessment charts, we'll come to know about, we can have an idea about the estimated blood loss and the associated symptoms like dysmenorrhea. So our clock starts ticking itself when the patient tells about severe dysmenorrhea or dyspareunia about making a diagnosis, and intermenstrual bleeding or postcoital bleeding. So we have to have an in-depth questioning regarding the amount of bleeding over the entire length of cycles, the number of bleeding days which are free between the two periods, and when did the abnormal bleeding pattern started. So we have to ask her that nighttime change of pads, how much she changes, because it is not normal to change the pads at night. And the size of the clot, less than 1 inch clot is okay, but if these are more than 1 inch clot and the number of clots are more, then it is abnormal. Likewise, soiling of bed clothes at night. And if you can see the symptoms of anemia, you can easily collaborate that this is a case of heavy menstrual bleeding. And nowadays, the use of menstrual calendars and smartphone applications, they can provide us about an objective data regarding the menstrual cycle lengths. So we have to confirm that what the patient is saying is okay from these questionnaires which have been framed, like how often you change your sanitary pad during the days. Normally, it should be less than 21 pads or tampons per cycle. And do you need to change the same pads during the night? And what is the size of the clot? And have you been ever told by any medical practitioner that you are anemic? And the size of clot normally should be less than 1 inch in diameter. And if the patient is complaining of intermenstrual bleeding, the timing of the menstrual cycle where the intermenstrual bleeding is occurring, it is very important. If it is in the immediate premenstrual phase or the postmenstrual phase, it might point to an anovulatory cycles. Mid-menstrual spotting, we know it is an ovulation, spotting might be there, or post-menstrual spotting in a patient with cesarean section. Nowadays, we are seeing isthmocele because of the increase in incidence of previous two cesarean sections. And infrequent intermenstrual bleeding may be because of some submucous fibroid, polyp, or sometimes cervical erosions or some vaginal lesions. And the way the heavy menstrual bleeding is, if it is sudden, it may also point towards a coagulopathy. Now coming to the recent obstetric history, that what is she had a recent pregnancy or miscarriage, or she is having intermenstrual bleeding because of the place of IUCD in C2, or if she is using irregular contraceptives, OCP use irregular, she has left irregular OCPs, or she might have used in the earlier cycle or this cycle to delay periods, which is very frequent, that she is going for a tour or she is going for visit to some holy places, and then she has taken tablets to delay her periods, or she has taken emergency contraceptive pills. That is very much important. So unscheduled bleeding because of these hormonal contraceptive pills or IUCDs. This is very important. So coming to a case of an adolescent bleeding, she had infrequent cycles, heavy menstrual bleeding for the last 2 years. Her BMI was 26, so we can have an idea that she might be a case of PCOS. So in adolescents, I would like to stress that sexual and reproductive history is very much important. In unmarried females, we often sometimes hesitate to take the sexual history or the reproductive history, but nowadays it is important for us to consider them as sexually active unless they have denied. You have to take the girl in the confidence, you have to make her mother out, beat. So the patient might be very close to you, but still you have to elicit sexual history in adolescents. These adolescents are using emergency pills, they are taking irregular OCPs, which are contributing to their irregular cycles. Then past medical history, family history, and social history, we have to see. First day of LMP, the severity of bleeding, whether it's a postcoital sexual history should be known, and the history of previous surgeries like previous myomectomy or leap or any procedure done or her. Sometimes these AV malformations can also be a cause of irregular uterine bleeding. And we have to look for cases of galactoria, amenorrhea, as they might be pointing to a cause of hyperprolactinemia. Or she might be taking any antipsychotic drugs, or that might be contributing to irregular bleeding. And history of bruising, etc. थोड़ा सा भी कुछ होने पे bleeding होना, it might point towards a coagulopathy like von Willebrand's disease, which we should take into account, especially in cases of adolescents. The one thing other is important is whether she is doing any intensive exercises. Recently, she has undergone any weight loss or stress, sometimes place change, or sometimes just the pressure of examination or some heavy work. These can also coincide with menstrual cycle changes. And breakthrough bleeding while taking oral contraceptive pills should also be asked in history taking. The age of menarche can also be an important factor. Other things are LNG IUD. If she is taking, then it takes around 2-3 months for cycles to get regularized. The history from the partner is very important. She might be having vaginal discharge, she might be having cervical erosions and pelvic pain because of sexually transmitted infections. And she might be also a case of sexual abuse or extrauterine, some foreign bodies like that. And the history of recent miscarriage or delivery, it can also cause AUB, and endometritis or infection can be an important contributing factor. Coming to the past medical history, never forget to take history of any chronic illness like liver, renal disorders, or SLEs, which can affect coagulation. Diabetes or other endocrinopathies like thyroid, they can also alter the HPO axis. She might be taking some over-the-counter medications like aspirin or valproic acid. If she's on anti-seizure medications, they can affect coagulations. And antidepressants, they can also alter the HPO axis. Among history, the history of epistaxis, bleeding gums, post-operative bleeding, that's just important, and orthostatic symptoms, hypovolemia, significant blood loss, weight change or any weight loss, hyperhypothyroidism, malnutrition, or recent weight gain or PCOS. These are also very important. To rule out PID, the history of abdominal pain, fever, and vaginal discharge, we should elicit. If there is dyspareunia, dysmenorrhea, infertility, endometriosis, and adenomyosis, they clicking our mind. And to rule out hypothyroidism, cold intolerance, fatigue, and galactoria and visual disturbances in cases of hyperprolactinemia. Sometimes the bleeding might also be mistaken for a renal or a rectal cause, because she might be having changes in her bladder or bowel function, and sometimes she might be mistaking hematuria for a vaginal bleeding. And changes in skin, hair, nails, and joint problems can also point towards collagen disorders. And these are quite rare, leukemias, and also social history, some social stressors, substance abuse, exercise patterns, social absence from the school, decreased participation in recreational activities, because these might point towards certain depression, because and these might also affect the hypothalamic pituitary ovarian axis, leading to irregular bleeding patterns. So this is a pictorial blood assessment chart which we have been using, that we give 1 point for the smallest and 5 point and 20 points for the biggest. This thing, likewise, clot, if it is less than 1 inch, it is 1 point. If it is more than 1 inch, then 5 points for each. 1, 5, and 10 points for each lightly soaked pattern. So this pictorial assessment chart can also help us in sometimes in patients who are mentally retarded or other thing. Now coming to the examination, BMI is the most important thing which we can know about PCOS, weight, then coming to pallor, to know the degree of anemia. In the general examination, look for thyroid enlargement, thyroid swellings, hirsutism, acne, velvety at the back of the neck, acanthosis nigricans, evidence of any bleeding disorders, look for petechiae, ecchymosis, and breast examination to look for galactorrhea and to rule out hyperprolactinemia. Cervical, and for do a per speculum examination to look for any cervical or abdomen. Sometimes on per abdominal examination also we can look for uterine enlargement. If sometimes the fibroids are large enough or it's an adenomyotic uterus, then per
Sorry to
speculum.
interrupt you, ma'am.
Okay, but just 1 or 2 minutes.
Okay.
Per speculum examination, we have to look for this polyps, local cause of bleeding, vascular changes, or early cervical cancer can also be there. Don't miss an opportunity to look for pap smear, then do a bimanual examination. In the era of ultrasound also, don't forget to do a bimanual examination. Look for the shape, size, consistency of the uterus, the mobility of the uterus, the adnexal of masses, because fixed tender uterus, it might point towards endometriosis. And so normal pelvic examination does not exclude the possibility, because polyps and other things we can know from our investigations only. This is the same thing. Medication history may, sexual history, chlamydial cervicitis, PID might be there. So this is all we should do for a history and examination in a case of abnormal uterine bleeding.
Yeah. Dr. Ashok Padi, please conclude this talk.
Yeah. Thank you, Dr. Ruchika, for your
Thank you,
nicely elaborated all the aspects of history. And how history taking is a very important part of while dealing the cases of AUB, and we have nicely elaborated all the aspects of this history taking. Now I welcome the next speaker. The next speaker is Dr.
Arun, no, Dr. Padi, just a minute. Dr. Arun has been already introduced. Arun, are you with me?
Yes.
Dr. Arun Barua, please share your screen and start your presentation.
Okay.
No issue. Actually, I made my join at right at 5 o'clock. That time actually.
You're most welcome. I know.
Okay.
He was having
Thank you,
some
ma'am.
network issues, Dr. Madhav. So his talk is pending from the previous session. Yeah.
Okay.
Yeah. Please make it slideshow, Arun.
Yes.
Great. Please go ahead.
Thank you so much. And really, I'm sorry if I have made someone
No.
happy because of my network connectivity and other issues. I couldn't join little ahead. But anyway, I think the AUB is what we are discussing in a perfect way forward. Everyone in this country deals with AUB, especially all OBGYNs. And I'm here to talk about the pathophysiology. You all have given us the most important history, but this is what the clinicians must know in details. So I'll just bypass the whatever has been talked about and go directly into the pathophysiological part and try to look into what this PALM-COEIN classification contributes to the pathophysiology of this particular condition, which is gaining momentum, and also it is actually penetrating everyone in the society. We know the first one in the structural causes is polyps, and these are localized overgrowth of the glands, stroma, and the blood vessels. They may have a fragile vasculature and incomplete shedding surfaces, leading to intermittent bleeding, which can be labeled as AUB. The bleeding severity often doesn't correlate with the polyp size or number, and probably that is why in this classification, no particular sub-classification of this size and the location has been given. So going into the pathophysiological aspect, the local vascular abnormalities contribute a lot. Polyps often contain aberrant, thick-walled blood vessels with poor vasomotor control, and these fragile vessels may bleed easily during normal sloughing. Remember, these particular polyps have a tendency to recurrent, and that is why we need to treat them perfectly and enroot them in toto so that the condition doesn't recur. Incomplete shading is the way they mostly present with. The polyp surface may shed incompletely, leading to islets of functional tissues that bleed intermittently. The stromal changes, the polyps can exhibit stromal congestion, hyperfibrosis, and potentially creating a localized area of impaired circulation. All this have a clinical correlation, notably bleeding severity, and it doesn't correlate well with the polyp size or the number, but even small or few polyps can cause disproportionate bleeding, and that is why in a susceptible woman, this particular presence of a sometimes physiological changes can also become pathological. And that is why we need to understand that polyp contributes heavily to this percentage of abnormal uterine bleeding according to the PALM-COEIN classification. We go into the adenomyosis, the most baffling disease where we do not have an adequate treatment till date. We are all trying multi-pronged attacks from different corners, but yet we are failing to achieve the desired effect that our patients really want. It may result in a repeated injury and cause chronic inflammation, fibrosis, and also in some cases progesterone resistance. And that's why when you try to treat this group of disorder with progesterone, the traditional way of treating AUB, around 40 to 50% response, and the remaining doesn't respond because of the coexistence of progesterone resistance in adenomyosis. These changes lead to heavy and prolonged menstrual bleeding, and mostly the junctional zone disruption is the key factor. The endometrial fragments may invade the myometrium, and for example, due to repeated injury, leading to islands of bleeding tissue deep into the uterine wall. And looking into this particular junctional zone becomes a very, very minute and trivial affair for a sonologist or even a gynecologist to look into whether that particular woman has just been developing this condition or going to develop this condition, because if we try to treat in that particular moment, I think many of the conditions of this adenomyosis can again return to a normal pathology, normal condition. There are cases of myometrial hypertrophy. So adenomyosis often causes diffuse uterine enlargement, and thickened muscles is the rule. Some researchers suggest that hypertrophied inner myometrium could compress the overlying endometrium and promoting heavy bleeding, just like a fibroid classification of 2 or 3. Inflammation and fibrosis, which are a part of chronic inflammatory responses like endometriosis. So in adenomyosis, they may alter the uterine contractility, and the increasing fibrosis in lesions may spread to adjacent tissue and accentuate hypoxia and the repair signaling that is so important in controlling normal menstrual function and repair. For instance, dense fibrosis could impair endometrial regeneration, after sloughing. The hormonal factors are here to stay. Adenomyosis tissues often have aberrant estrogen and progesterone receptor expression and possibly leading to localized progesterone resistance and abnormal desensitization, which could predispose to abnormal uterine bleeding by affecting the normal menstrual cascade. So we come to the most common cause of AUB, the leiomyomas. Every third woman does have a leiomyoma, whether they're symptomatic or asymptomatic. I'm not talking of that, but the presence of a leiomyoma is so common in our country. They are known as the benign smooth muscle tumors that disrupt the uterine cavity and also the blood flow. And when it enlarges in size, it actually exerts pressure to the nearby important organs. They increase in the surface area, secrete factors that promote bleeding. They also interfere with the uterine contractility and vasoconstriction, and all these mechanisms contribute to the AUB. The endometrial surface and the cavity changes becomes quite obvious. The large fibroids can increase the overall endometrial surface area and the stress on the uterine cavity, creating more tissue to shed. Simply, if it is existent, even though it is not 0, 1, or 2. Mere by its volume, it causes increased blood loss during menstrual cycle. Vascular dysregulation is also pretty common. So fibroids are highly vascular along with the thick wall blood vessel, and that is why when we do a myomectomy, we see tremendous bleeding during the process, and we all know what are the ways to tackle when we do a myomectomy. And these thick vessels can alter the uterine blood flow, and the theories include the dilated vessels, overlaying fibroid, venous congestion due to pressure, and the angiogenic factor actually may be a very important contributing factor which imbalances the balance between a normal myometrial tissue and an abnormal fibroid tissue that is growing. The studies shows that fibroid uteri often have more venous plexuses and a different expression of angiogenesis genes than the normal uterus. In many, that has been postulated there are the prolactin or hyperprolactinemia can also lead to the presence of myomas. The research papers are on. The consensus is yet to arrive, but that concept is also gaining quite momentum in our country and in few centers abroad. The myometrial contractility, that is basically the submucosal component, may disrupt normal uterine contractions and the spiral arterial tone, preventing efficient compression of the bleeding sites and contributing to the irregular contraction and the proposed that is existing in fibroid uteri, especially of type 0 or even type 1 and 2. There are certain paracrine factors, fibroids secrete or induce changes in the growth factors, prostaglandins, and the cytokines. For example, TGF-beta3, altered matrix metalloproteinases, and then they may create a bleeding atmosphere which is so suggestive of abnormal uterine bleeding from the endometrial milieu. Moving beyond this, we have malignancy, and we all know how malignancy contributes. So the pathophysiology of malignant AUB will not be discussed in this presentation. Coming back to the bleeding disorder, the coagulopathy, pretty common in our country. AUB-C, that is coagulopathy, is due to systemic bleeding disorders such as von Willebrand disease or the platelet dysfunction. In our part of the country, platelet dysfunction is more common than the von Willebrand disease, and these conditions impair normal clot formation, resulting in prolonged and heavy menstrual bleeding despite normal uterine anatomy and ovulation. Looking into the mechanism, during endometrial shedding, normal coagulation, which is formed by the platelet plug and the fibrin clot, is essential to stem the bleeding. In AUB-C, the clotting factors or the platelets are deficient, so the clots form poorly and the bleeding continues for a longer period of time, contributing to abnormal uterine bleeding. In von Willebrand disease, the most common form of the AUB-C, when you look into the national perspective in general, the hemophilias, the platelet function disorders, roughly 13% of the women with heavy menstrual bleeding have an underlying coagulopathy, either primarily or secondarily. They present typically with heavy flow since menarche, and they may bruise easily. And that's what my previous speaker has given you. Taking history is so important in cleansing and diagnosis, or at least writing the investigation what is relevant for that particular lady. Ovulatory dysfunction today has become so important because of hyperlipidemia and also so much of altered BMI amongst the girls and the women that we deal with. So ovulation in this AUBO is either absent or irregular, resulting in unopposed estrogen stimulation. This leads to continuous endometrial proliferation and irregular shedding. And in this group of function, progestogens will really benefit. And that's how we can indirectly conclude that this abnormal bleeding was mostly due to ovulatory dysfunction. Conditions like polycystic ovarian syndrome, stress, weight changes are common causes, and bleeding is often heavy and erratic. Excess estrogen and no progesterone. Without regular ovulation, estrogen drives continuously the endometrial proliferation. The thickened endometrium eventually outgrows its blood supply and partly sheds irregularly. Remember, we treat estrogen also to control heavy menstrual bleeding, that too at a higher doses, so that the endometrium regenerates and it controls the bleeding. In irregular bleeding due to ovulatory dysfunction, bleeding is often erratic, from scant spotting to heavy flow. All the varieties can happen depending on when a withdrawal bleed occurs. AUBO arises when ovulation is absent or irregular, leading to inappropriate sex steroid exposure. Examples like hypothalamic, pituitary, or ovarian disorders, hypopitulosis is in play. Excess estrogen, no progesterone, that has already been explained to you. The outcome is chronic and ovulation and typically leads to heavy, irregular cycles. And since no timely luteal phase progesterone is secreting, and that is why bleeding often becomes heavy and prolonged. Now, a very underrated.
Sorry to interrupt you, sir. So
Yes.
your time is up.
Hello.
Okay, then I'll conclude.
Yeah,
Fine.
please.
Arun, sir,
Yes, Arun.
Okay.
Sir,
Fine.
last 1 minute, unfortunately, the time we have exceeded, sir.
No, that's fine.
Yeah,
Then
Arun, please, yeah, conclude your talk. Yeah.
Okay. No, I have only, this is what the normal physiology we are trying to talk about. The menstrual phase we all know about, nothing much about endometrial shedding and repair. Progesterone withdrawal leads to activation of inflammatory pathways and matrix metalloproteinases, which degrade the endometrial lining. Because I was trying to take every etiology one by one. So when we know this physiology, it is very easy to depict what is the pathology. And I'm sure the molecular dysregulations also comes into play. And if you know the mechanism, if you know the pathophysiology, the treatment becomes so easy. And when you don't know the mechanism, there are many which are yet to be delineated, and research protocol is going on. And I'm sure we are trying to do our best in trying to understand this condition. So AUB arises from multifactorial disruption involving hormonal immune factors, vascular and structural elements, improved understanding of hypoxia-inducible factors, immune responses and receptor pathways is essential for better diagnosis and treatment. And AUB occurs when any component of normal menstrual tissue injury and repair cycle is disturbed. Thank you so much for allowing me to make this presentation. I'm ever grateful to ICOD and the officers in the HAM in the ICOD. Thank you so much.
Thank you, Arun. Ritu, are you here? You can conclude
Yes,
this
yes,
topic.
madam.
Please, yeah.
Yeah. So thank you so much, Arun Barbasa. And it was really an insight, going into the whole pathophysiology. And of course, we got to know that if you know the physiology, you're a master for the pathophysiology too. So
Right.
thank you so much. It took us into depth. And can I go ahead introducing the next speaker?
Yeah, please introduce Shashiwala. Yeah.
So
who is Apurva Kumar? Yeah.
Yeah, so it's a pleasure to introduce Dr. Apurva Kumar Datta, who is the Chairperson Sexual Health and STI Committee, FOXY, and has been the National Coordinator for FOXY CME Workshop for the Safe Abortion and Contraceptive Cafe 2020. He's got a lot of awards to
Thank
his
you.
credit,
Thank you
and of
so
course,
much,
very
Ritu ma'am.
versatile, very creative. Thank you, and over to
Thank you,
you
thank you,
for
thank you so much. Yes,
laboratory
ma'am.
investigations in AUB.
Yeah. So thank you so much. At the outset, I would like to thanks to ICOG Chair, Dr. Parag Viniwale, sir, the Secretary General, our dear Sarita ma'am, and very lovely the past ICOG chairperson Lakshmi ma'am for giving me the opportunity. And it's really, ma'am, the internet is boom with the so many participants. And I have listening the lectures. It was really an eye opener for me also. So thank you so much. So let me start and share my screen. Though it is very small, but it is very important to know what are the lab investigations for the in case of AUB. Sorry.
Yes.
Is it visible? Yeah.
Yes, yes, yes.
So my dear friends, when we know the causes, the pathophysiology, the clinical history and the examination, the next thing is actually the laboratory investigation. So the first and foremost investigations which we have, irrespective of the age, the marital status, irrespective of the history, is to exclude the pregnancy. Whether it's a young age, whether it's any age group, adolescent, the patient is divorced, the perimenopausal, first exclude the pregnancy. Many times we are unable to confirm them. So do not go for the urine. You can do a serum human chorionic gonadotropin test, but first to exclude the pregnancy. Now the investigation which all of the person should undergo, patient undergo, is the CBC, that complete blood count, to evaluate the anemia and thrombocytopenia, and definitely the ABO-RH. Why ABO-RH? To know whether if she is anemic, whether she need a blood or not. So this is the basic investigations. Now, after that, the additional investigations should be performed as per the clinical sign symptoms. So the first and foremost is the thyroid function. It is to assess the patient with the sign symptoms of thyroid disease, or even if the patient doesn't have the sign symptom of thyroid disease, please do it, and definitely it's a first line of investigations in case of AUB, because many of the cases are actually the thyroid, if not overt, but maybe the subclinical hyper or hypothyroidism. Now, the other hormone evolution, the specific hormone test are the prolactin, again, very important, the androgens and estrogen. Now, mind it, the estrogen should be reserved for the cases with the clinical suspicion of the endocrine dysfunction, for example, the anovulation or hyperprolactinemia, and not in all the cases. Now, coming to the bleeding disorder. So initial screening include the platelet count, the thrombin time, and the partial prothrombin down, that is PT, APTT, and platelet count, almost in every cases. But the factor like von Willebrand factor, factor 7, these are actually not recommended in each and every cases. It is only reserved in a cases where you are suspected that yes, it might be a case of the coagulation disorder. Now, when we are thinking that it might be case of coagulation disorder, for example, a patient is coming for especially the young adolescent girl who is presented with the heavy menstrual bleeding and having any other of these symptoms. For example, the duration of the menstruation having the 7 or more days, the women report either gush of blood or bleeding through a tampon or napkin in 2 hours or less with most period. The history of treatment of anemia in the past, either in a form of blood transfusion or in a form of hematinics or in the form of injectable irons. Or there's a family history of diagnosed bleeding disorder, or there's a history of excessive bleeding with the previous surgeries, for example, tooth extraction, or in case of delivery or miscarriages or the surgery. So these are the cases where the specific coagulation profile is warrant, and we have to go for this, like von Willebrand factor or factor 7, etc. Now coming to the ferritin level. So what the ferritin level is doing? So ferritin level should be assessed even each and every cases to evaluate the iron storage, because many time on seeing the hemoglobin level and it's okay like 10 or something like that, but when we are going into the deeper, the ferritin level is actually very low, and when the patient is coming with a one bout of bleeding, then the hemoglobin is dropped to 7 from the 10. So ferritin level is again very important. But a low ferritin level indicate the iron deficiency, though normal level may not rule out anemia due to the inflammatory state if the inflammation is present in the body. So that we have to do the ferritin level. Now coming to the cytology, as Ruchika ma'am has already stated that the pap smear or liquid-based cytology is again important. Now, this is not directly related with that. It's not like that that the cervical pathology is directly related with the AOB, but for evolution of the AOB, when you are suspecting that there may be some problem, some might be problem in the cervix, we have to do the cytology. Now, coming to the chlamydia and gonorrhea. My dear friends, chlamydia and gonorrhea is not very uncommon. Last month, I have seen 4 cases of gonorrhea in my OPD. So these have really very important, and chlamydia is definitely is somewhat directly related to the AOB. So many times we have to go and investigate about the chlamydia. Now the retroviral screening, that is the HIV. Again, HIV is not directly related with the AOB, but the problem along with the HIV, the mechanism, or when it's decreases CD count for, it seems that it may be related with the AOBs. So it is indirectly related with the AOB, and we have to give these lab investigations. The other investigations which is not routinely done, but in case of acute cases, we need to do is the LFT, is the renal function, and the adrenal function. Now coming to the adrenal function. Now why adrenal function? AOB is not directly related to the adrenal function, but the hormonal imbalance caused by adrenal issue or the body response to the stress can potentially lead to the AOB. Now this is very important, because I have always seen, in the month of February or in case of March or January, when the board exam is coming, the parents are taking the young adolescent to me and they are saying, Doctor Sahab, pehle to bilkul periods normal aate the. I don't know what happened. Now the periods are irregular. So it is actually due to the stress factor. So many times when it is the stress factor, it is through the adrenals which cause the AUB. Now, if you are suspecting certain adrenal tumor, then we have to detect for the adrenal investigations. Or if there is a adrenal insufficiency, can lead to the various hormonal imbalance, which might directly or indirectly affect the menstrual cycle and potentially contribute to the AOB. So this is about the adrenal. Now coming to the KFT. Now again, the KFT is not directly related on kidney function test. The imbalance is not directly related with the AOB, but indirectly, yes, when there is a chronic kidney diseases are there, it actually disrupt the normal hormonal balance, and when there is a normal hormonal balance is disturbed, it may lead to anemia, it may lead to menstrual irregularity, so can lead to the AOB. The third is the LFT. Again, it is not related with the AOB, but they can be included in the initial workup to rule out the other potential cause of the abnormal uterine bleeding, particularly if the patient has other sign and symptoms or any risk factor. So these are the 3 investigations which are actually reserved and not doing regularly. So these are the laboratory investigations. So what is the specific consideration for the adolescent? Yes, we have to rule out the pregnancy. We have to do a CBC. We have to do thyroid function test. These are absolutely recommended. In case of adult, in addition to the above, the endometrial biopsy and imaging can be considered, which I think my next speaker will be dealing with. So now how to evaluate the lab investigations? The first step, the pregnancy test, then the complete blood count, the ferritin or iron incidences, the prothrombin time, APTT, that is activated partial prothrombin time, PT, fibrogen, blood type and cross matches. The second step is the thyroid stimulation hormone, the Wall Willebrand panels, or the factor 8, factor 7, chlamydia, Neisseria gonorrhea, total and free testosterone, dihydroepiandrosterone, when we are detecting that, yes, this might be cause of adrenal insufficiency. These are the investigation panel. And the third step is when we are suspecting any coagulation disorder, then the platelet function and aggregation test is recommended. So that's all all about the lab investigations of the AUB. Thank you. Thank you so much, ma'am.
Thank you, Apup. That was, I think, a very, very crisp and a crystal clear presentation. And it is a great insight into the very important and integral part of the AUB investigations. Like you said, ferritin, normal, still, you cannot rule out the inflammatory states. I think it's really, this is going to direct you, to your diagnosis and I think your further management. So thank you once again. And thank you, Lakshmi Madam and Paraksa and Sarita Ma'am for this fantastic, the master classes. And over to Shashiwala
Thank
for
you. Dr.
introducing
Shashi,
the next speaker.
you please
Yes,
invite the
yes.
next speaker. Yeah.
Thank you so much.
Yeah.
Dr.
May
Sonal,
I
are
have
you here? Dr. Sonal Pancha? Yeah.
Yes, Dr. Sonal Pancha. Before
Yeah.
that, thank you so much, Lakshmi ma'am, for inviting me. And of course, Parag Beniwale sir and all the chairpersons and my dear speakers. So now Sonal is consultant, Dr. Nagori's Institute for Infertility and IVF, Ahmedabad. She's PhD in ultrasound in gynae and infertility, Masters in ultrasound from Iron Donald School of Ultrasound, Professor Dubrovnik International University. She's National Academic Director in Iron Donald School, India. And now she's Director, Center of Excellence, Iron Donald Inter-University School of Medical Ultrasound, Ahmedabad, India. She's on the National Advisory Board, member of International Journal of Infertility and Fetal Medicine. She's reviewer for Journal of Human Reproductive Sciences, and she's published many papers and delivered more than 800 lectures. So over to you, Sonal. We are agog to listen to you. I invite you, Dr. Sonal.
Sonal, are you with me?
No, ma'am, not joined yet.
Sonal is not here.
Oh,
Okay.
God.
Next speaker.
Pratibha, Dr. Pratibha
Pratibha
Singh.
is here. Dr. Padi, will you please introduce Dr. Pratibha Singh?
Yeah, thank you, ma'am.
Yeah.
So let me introduce Dr. Pratibha Singh. She's a consultant laparoscopic gynecologist and IVF specialist, Director Healing Touch Hospital, Bhagalpur, Chairperson IAC Foxy 2022-25, Chairperson Fertility and Aging Committee, President Bhagalpur Menopausal Society, and she is presently affiliated to Diploma for Advanced Gynec Laparoscopy, Diploma in IVF from Dubai, past Honorary Secretary BOJS and IMA Bhagalpur. And her major achievements are is authored of Foxy Focus books and GCPR and presented papers and contributed chapters in various national and international journals and conferences. Is a recipient of Dhira Award in the year 2023, distinction of honorary professor of IMF 2022.
Thank you so much.
Thank you. Now the stage is yours, Dr. Pratibha. So we have met just few days back in Prachikan.
Yeah.
Can you remember? Yeah.
Yes, sir. I can see Sarita madam if madam can want to say something.
Yes, Sarita, please unmute. And
Unmute yourself,
Apurva,
madam.
there are many questions. Please answer in the chat box before you log out. Yeah. Yes, Sarita, please unmute.
Madam is not able to unmute herself.
Yeah. Yes.
Hello, everyone. I'm listening. Yes, I'm enjoying it. I think you can go ahead. I don't want to take away any time.
Okay, madam. Okay.
Thank you.
Can I share my screen?
Yeah, Pratibha, we can see. It's coming. Yeah, it has come.
It's coming, no? Yeah.
Yeah.
Okay. Is it full screen?
Make it slide slow.
Ma'am, please use that slideshow option on the top.
Slide slow option. Yeah.
Is it slideshow?
Now it is.
Now it is.
It's slideshow?
Yes.
Yes, sir. Yes, ma'am.
Okay. So good evening, everyone, respected chairpersons and my dear friends. First of all, I want to thank the ICOG chair, Dr. Parag. I cannot see anyone. I don't know why. Yeah. So I want to thank Dr. Parag sir and Dr. Sarita madam and Lakshmi madam for giving me this opportunity. And today I'll be talking on, just a minute, I cannot see anyone. I have to talk on role of endometrial sampling, when it should be done, how and what should be its interpretation. So endometrial sampling or biopsy is a simple and effective office-based procedure
that samples the endometrium to allow for direct histological evaluation. And it is a primary role to ascertain the existence of pre-malignant or malignant intrauterine pathology by reviewing pathology results. And it is mainly recommended in those patients who have abnormal uterine bleeding, who are above 45 years of age, or even in the younger patient with significant risk factors like endometrial hyperplasia, endometrial intraepithelial neoplasia, or cancers, or in the patients with postmenopausal bleeding. For endometrial sampling should have adequate sample which should contain both glandular and the stromal tissue, because that will give you the highest accuracy for detecting all types of endometrial pathology, even though if you have a small tissue for sample. It is a very easily performed procedure which can be done in outpatient setting independently and is a relatively quick and cost-effective way of sampling the endometrium. And it should be an essential skill to everyone, because most of the time endometrial cancers are quite common in women, but often they are missed and often they have a very different type of presentation. So if the patient has endometrial hyperplasia on imaging, or if she has some abnormal uterine bleeding which is not responding to treatment, then such patients should be sent for endometrial sampling, because sensitivity for detecting endometrial abnormalities is as high as 96%. And the interpretation of biopsy results guides further management, potentially including further testing or treatment. So it is mainly done for abnormal uterine bleeding, or for evaluation for endometrial neoplasia or precancerous hyperplasia, or for surveillance of previously diagnosed endometrial hyperplasia or cancer, or sometimes for evaluation of the uterine response to hormone therapy. And it was also used to know the status of endometrium in infertile patient and dating, but now it's not been used that much because there are other options available. Now, whatever samples we take, it should be adequate. Although there is no definite guidelines or arrangement that what is adequate, but whatever tissue you get, if that can make a diagnosis, that is adequate. And for that, clinical details are very important. Like when you are taking the samples, you should document the clinical detail, like the age of the patient, her presenting complaints, then other things like what is her menstrual status, or what is her last menstrual period if she's menstruating, or her menopausal status, or if she is on any hormonal therapy and all. And same way, when you send the sample to the histopathologist, they should also document and write the clinical details, like what type of sample they have received, like whether it is a strip of endometrium or whether the sample is enough or not. They should not be writing inadequate. Rather than that, they should find out by writing no stroma, or proliferative without definitive stroma, or no endometrium, or they can simply write no tissue received. Now, this is the algorithm for assessment of adequacy of endometrial biopsy specimen. So once you get a specimen, endometrial biopsy specimen, if there is no endometrial tissue, then it is labeled as inadequate sample. And if patient has abnormal ultrasound or strong clinical suspicion, that patient should be subjected for rebiopsy. If you receive superficial strips of endometrial gland, in that case, they should be labeled as unaccessible sample. And if they have normal ultrasound, then there is no need for rebiopsy. But if again there is any abnormal ultrasound findings, or there is strong clinical suspicion, then they should again be subjected for rebiopsy. When you get intact organized tissue, that should be typed and specimen should be given. Now, for endometrial sampling, it has a very low yield of significant abnormalities, and it is also not cost effective. So it is not recommended as a screening tool for cancer. While doing endometrial sampling, clinical history is very important. I've already told that you should always take the age of the patient. You should also write the reason for biopsy, then menstrual status, menopausal status, her last menstrual period, then length of the menstrual cycle and all. And sometimes these patients who are having abnormal uterine bleeding, they must be taking some exogenous hormones like progesterone compound to control bleeding, or HRT, or they must be on contraceptives. So that all information should be conveyed to pathologists, because that may alter the morphological appearance of the endometrium. Now, these are the different methods of doing endometrial sampling, that is by curating, which is the old aged procedure. Pupil biopsy, which is now most popularly and most conveniently can be used because it is a outpatient procedure and does not require any anesthesia. And hysteroscopically directed biopsy is the gold standard. In recent years, several publications have reported that accuracy of DNC is limited with false negative rates as high as 10%. And one explanation for this can be that it is a blind procedure. So most of the time you are not able to curate whole of the cavity and you may miss the lesions. So if it is combined with hysteroscopy, it may be superior. Although the pupil biopsy is more sensitive, especially in the perimenopausal women, because that can detect endometrial cancer as high as 91%. And for the postmenopausal women, it can detect as high as 99.6%. But the problem arises when you get insufficient sample. So those insufficient sample again require further investigation because it has been seen that about 20% of such patients can have uterine pathology, and out of these 3% may have malignant disease. So such patients where you get insufficient samples, in that case, they should be subjected for hysteroscopically directed biopsies. Now this is the pupil biopsy, which is very commonly, I think everybody must be knowing it. And this is a very soft, thin catheter, plastic catheter, and that is introduced inside the uterine cavity up to the fundus, and then piston is withdrawn, and the biopsy that curate has comes out, and then you can just move in and out so that you can get the endometrial tissue. And if there is a loop, so that loop should be rotated clockwise or anti-clockwise direction for 10 to 15 circles, and then you can collect the endometrial cells and can send for histopathological examination. According to RCOG guidelines, it emphasizes a structured approach to interpreting endometrial sampling, particularly in context with endometrial hyperplasia, and WHO has classified hyperplasia into two groups, that is hyperplasia without atypia, which has low risk of progression, whereas atypical hyperplasia, which can significantly has a higher risk of progression to cancer. For hyperplasia without atypia, again, you should address risk factors and you should consider observation, and progesterone treatment is the option. You can keep the patient for surveillance for 6 months with biopsy. Unless you get 2 consecutive negative biopsies, then you can continue with that. Or those patients who have high risk, they should be kept for long-term follow-up. Whereas for atypical hyperplasia, hysterectomy is generally advised, especially for the women who have completed their families. But those females who want to keep their fertility or their uterus intact for fertility purpose, then fertility sparing management with LNG IUCDs or oral progesterone are the options. And finally, you should counsel them regarding and should rule out the invasive cancers, and they should be kept under follow-up lifelong or till they go for hysterectomy. Guidelines also emphasizes the importance of proper interpretation to diagnose and manage various endometrial conditions, including hyperplasia and cancer. And the first line investigation is transvaginal ultrasound, where you see the endometrial thickening, and the cutoff is 4 millimeter. Hysteroscopy directed biopsy is the gold standard for diagnosis, and interpretation of the biopsy result is crucial for determining appropriate management. Now, this is the key aspects of RCOG guidelines on endometrial sampling interpretation. So, initial assessment with transvaginal ultrasonography with the endometrial thickness, where the cutoff is 4 millimeter. If the thickness is more than that, and if the bleeding persists, then they should be subjected for endometrial sampling. Hysteroscopy allows for direct visualization of uterine cavity and enables targeted biopsy of any suspicion area. And the biopsy results, the normal result is when you have proliferative or atrophic endometrium, they are considered normal. And if there is endometrial hyperplasia with or without atypia and endometrial carcinoma are considered abnormal and require further management. For endometrial hyperplasia, there is a specific guidance on the management of it. Like it mainly depends, the treatment monitoring and the treatment mainly depends upon the presence or absence of atypia and the women's reproductive wishes. For endometrial cancer, the guidelines outline the staging and the treatment options, which may include surgery, radiation, and chemotherapy. Now, the guidelines also emphasizes the importance of obtaining an adequate endometrial sample for accurate diagnosis, and it also highlights the importance of considering individual risk factors for endometrial cancers such as age, BMI, history of unopposed estrogen exposure when interpreting endometrial biopsy and results and planning for further management. Now, women with endometrial hyperplasia or those who undergo treatment for endometrial cancer will require further follow-up to monitor for recurrence or progression. So with this, I want to conclude saying that in the evaluation of endometrial biopsy specimen, an adequate clinical history is important, including detail regarding the use of exogenous hormone. In postmenopausal women with atrophic endometrium and no focal lesion on ultrasound, and with the presence of scanty endometrial tissue that is considered as normal. When endometrial biopsy is carried out for abnormal uterine bleeding, the pathologist should always consider the possibility of polyp because serous carcinoma or endometrial intraepithelial carcinoma have propensity to arise in endometrial polyps. So you have to be careful in these patients. All endometrial cancers should be typed and, if appropriate, graded even for small biopsy specimens. And in conclusion, the gold standard for evaluating endometrial pathology is hysteroscopy with biopsy, but the Pipple device is also fairly simple and effective office-based procedure technique in endometrial sampling. Thank you for patient hearing.
Thank you, Pratibha ma'am.
Yes, Shashivala. Please unmute. You can conclude.
Yes, thank you, Pratibha. As usual, crisp and to the point, and all about biopsy, how to take, and what about inadequate, because most of the time the result comes as inadequate. So the pathologists are very, just do it like that. So thank you so much. And it was really worth listening to, and take home message was ultimate. Thank you.
Sonal has been already introduced. Sonal, please start your speech here. And Pratibha, please answer questions in the chat box here.
Okay, thank you.
Yeah. Really sorry to be late, Dr. Lakshmi. Please forgive me for that. Starting with the presentation right away, and we'll try to finish up within time. Imaging in. Continue to share. Okay.
Yeah, we can see. It's in slideshow. Yeah.
Imaging in abnormal uterine bleeding. We all know the causes of abnormal uterine bleeding. And polyps, adenomyosis, leiomyomas, malignancies, and hyperplasias, coagulopathies, ovulatory disorders, endometriosis, and of course endometrial reasons, and of course iatrogenic causes. But it is very important that not all of this can be definitely diagnosed by ultrasound. There are coagulopathies and certain other iatrogenic conditions where maybe ultrasound or even MRI may not be a very good modality to evaluate these patients, and that's where clinical examination is required. Let us start with the abnormalities where we can use still ultrasound chiefly, and as and when required, add CIS or MRI for the diagnosis. Starting with the first one, the polyp, we know it appears as a solid echogenic lesion in the endometrium, in between the lines of the endometrium. It is easy to diagnose in the periovulatory phase when the endometrium is multilayered, but if it is large and if it fills up the entire endometrial cavity, that is when it may be difficult to diagnose. Not only that, you can see here also with peristalsis in the early proliferative phase, it may be seen moving and may be confused with blood clots, and therefore Doppler is very important. Doppler has to show a single feeding vessel, which is diagnostic, but it is also to be understood that polyps often may be multiple, and when they are multiple, that is when individual feeder vessel for individual polyp leads to a confusion and may lead to misdiagnosis of a hyperplasia at times. Yes, it is true that because the polyp surface is very smooth and the endometrial surface is smooth, therefore you may often get a bright edge. You may often get a bright edge or a fluid slit inside the endometrial cavity, which may be diagnostic. It is also important to differentiate the polyp from hyperplasia or any or an atypia of the polyp, especially when you see branching in the polyps. Branching is quite common in adenomyomatous origin of the polyp. That is when the polyp also appears heterogeneous. So a heterogeneously a polyp that appears heterogeneous and a polyp that shows branching of the vascular stem into the polyp, which it may indicate either adenomyomatous polyp or atypia in the polyp. So these polyps need to be seen very carefully. And if you measure the flow in the vessels which are inside the polyp, if they have a lower resistance, you suspect atypia in these cases. I did tell you that when the polyps are large and fill up the entire endometrial cavity, that's when they may be mistaken for hyperplasia. This may also occur when a single polyp is not large, but there are multiple polyps, and it is in these cases that we need to differentiate more carefully. Looking at the entire endometrium and spanning across, no bright edge, no fluid slit, mild hyperechogenicity with multiple anechoic areas is what tells us it is hyperplasia. We know that it is both in the polyp as well as hyperplasia that the junctional zone is clear, and therefore this cannot be used as a differentiating point. Though, when we talk about hyperplasia also, it is important to make one extra differentiation, and that is between the stromal predominance in hyperplasia and glandular predominance. When it is a stromal predominance, the anechoic area that you see in the endometrium are tiny and they're all almost same in size, whereas in the glandular predominance, there are multiple anechoic areas. They may be larger and smaller, variable in size. Moreover, when you put on a Doppler, it is also important to notice here that the stromal predominance usually is hypervascular, whereas the glandular predominance is usually hypovascular. Hyperplasia again needs to be differentiated from malignancy also, and the very clear sign that I told you earlier was intactness of the junctional zone, which has been described in the literature. But it is important to understand that as long as the endometrial carcinoma is in situ, the junctional zone will still be intact, and therefore it may be difficult to differentiate from hyperplasias. But the heterogeneous or non-uniform echogenicity of the endometrium especially is fairly diagnostic of possibility of atypical cells in the endometrium and atypia, and therefore early malignancy. It is also important to notice here that though the hyperplasia usually shows a regular and a symmetrical distribution of the blood vessels, whenever there is malignancy, there is heterogeneous vascular density. In some parts, the vascularity is very dense. In some parts, it's not there. And this is because of the necrotic areas. If at all the junctional zone is altered along with the heterogeneous echogenicity of the endometrium, that is where the diagnosis of the malignancy of the endometrium becomes much more easier. It is in these cases that myometrial invasion is suspected. The same echogenicity that is seen in the myometrium extends into the same echogenicity that is seen in the endometrium also extends into the myometrium. And not only that, even the vascular pattern, the similar vascular pattern which is seen in the endometrium also extends into the myometrium. Till the extent you can say, I mean, as far as the extent the vessels extend, you can say that malignancy extends till that level. The best tool probably to diagnose or to differentiate between polyp, malignancy, and hyperplasia would be 3D ultrasound, but 3D ultrasound also, especially when it is combined with saline infusion sonohysterography, where you need to introduce only about 3 to 4 ml of normal saline into the endometrial cavity. You may use either a dedicated sonohysterocannula, or you can also use a small pediatric Follis catheter. And that can be of great help to exactly identify the margins of the lesion, as you can see here, and it very clearly identify the lesion here. All the 4 images are of the polyp. You may also see sometimes multiple polyposis. You can easily find the pedicle of it, and you can also know from which wall it arises. Hyperplasia appears as an entire thick wall, and malignancies, of course, are very different because they have a differential density of the soft tissues, and they would not show any fluid inside the endometrial cavity most of the times, because the cavity is majority of the times obliterated. If at all the cavity is seen, it is absolutely irregular in shape. Micropolyposis is also one of the important findings for the endometrium, and it may be a cause of AUB. This is very common in endometritis, especially when it is tuberculosis. Apart from this, in tuberculosis, you may also see hyperechoic flex in the endometrium, in the junctional zone, sometimes in the myometrium. You may see fluid in the endometrial cavity with hyperechogenicity of the inner wall of the endometrium, but typically there is no vascularity in the subendometrium and the endometrium. Scarring may be seen, narrowing of the cavity is common, but the most sensitive sign, most specific sign for the diagnosis of Cox endometritis is vertical orientation of the interstitial part of the tube, and this is where 3D ultrasound is very, very helpful. It also needs to be remembered that tuberculosis sometimes may even show a multilayered endometrium, but when this endometrium shows irregularity of the central line, tiny hyperechoic flex in the outer margin or in the central line, and it also shows adynamic endometrium. These are also possible findings in tuberculosis and need to be remembered. Adenomyosis, hello. Adenomyosis is also one of the causes of globular uterus heterogeneous myometrium because of hyperechoic dots and lines, because of anechoic areas, myometrial cyst, junctional zone is irregular. And of course, you may sometimes see abnormal curvature of the endometrial cavity, which is called a question mark sign. These are all the signs of adenomyosis on 2D ultrasound. You may also sometimes see typical alternate hyperechoic strands, vertical strands of shadows, and this is called a rain in forest appearance, or it may also be called fan shadows. Typically, the adenomyosis shows vessels which have a larger diameter than the normal spiral vessels, but not all adenomyosis are going to be hypervascular. You may see a rim of vascularity surrounding the endometrial cyst, and there is a chaotic arrangement of the blood vessels. Apart from that, 3D helps you see the extension of the endometrial strands into the myometrium. Not only that, it would also show you the details of the junctional zone very clearly. Of course, for adenomyosis, at one time, MRI was considered a better modality, but with the advent of the 3D, now the junctional zone can be evaluated as in detail as MRI, and therefore 3D ultrasound is now considered as at par modality with MRI, considering the same parameters, 4 millimeter difference in the thickest and the thinnest part of the endometrium myometrial junction, or a junctional zone thickness of 12 millimeters. Fibroids may be caused, especially when they are subendometrial. It is in this fibroids, we all know hypoechoic roll pattern, round or oval or lobulated lesions with peripheral vascularity. They may show heterogeneous vascularity when they have they are degenerated. That's when they will also show internal vascularity. The vascularity is limited to the margins of the lesion only. And it is in this cases that 3D ultrasound is of a great help to exactly find out how much is the invasion of the endometrium. These type O fibroids can be differentiated from the polyps by checking the lesions in the luteal phase. Fibroids being hypoechoic are much better seen there. You may see a rim of vascularity, and intactness of the junctional zone tells you it is, infolding of the junctional zone tells you it is a fibroid rather than a polyp. Degenerated polyps may also lead to severe pain and sometimes AUB, and they may mimic adenomyosis, but elastography is one of the great modality which shows fibroids as dark blue. Even if they are degenerated, they are hard and consistency, whereas adenomyosis usually appears soft and comparatively soft. So it appears on the spectrum of elastography, it appears green-yellow. It is important to also document if there is a possibility, if there is a history of pregnancy, earlier pregnancy. It may be it may be, and the endometrium shows multiple anechoic areas extending into the myometrium. This may put on a Doppler, blobs of color may tell you it is a possibility of enhanced myometrial vascularity. And this is a lesion which should not be missed, because pregnancies, though are not very common in the advanced age, but it is in this cases some PCOS patients may present with accidental pregnancies go undiagnosed, and there is also a possibility of retained products of conception in these cases, which may ultimately show up only as myometrial vascular blobs, which is typically.
Sorry to interrupt you, ma'am.
Sorry, just last two slides. Is that okay?
Yeah.
Isthmosil
Yes,
is
ma'am, yes.
also one of the very important diagnoses not to be missed. It may present as bleeding in cases of so spotting and bleeding. Often, the larger the isthmosil, more will be the symptoms. But it is important to remember that if the patient doesn't have any symptoms at all, isthmosil is not a pathology which would require a treatment. Of course, when present, you need to evaluate it for its extension, not only into the extension of the fluid, not only into the endometrial cavity. It may sometimes also cause a fistula into the peritoneum. Cervical malignancies, again, cannot be missed. Ultrasound is a modality of choice, but in cases of malignancy anywhere, MRIs are an additional investigation to rule out the extension into the abdominal cavity and elsewhere, diagnosis of the lymph nodes, which may be metastatic. For the cervical malignancies, of course, apart from the enlarged lips, there may be variable vascular density, but 3D ultrasound is a great modality to find out the extensions and demonstrate the extensions into the parametrium anteriorly and posteriorly. Also, ovulatory dysfunction can be diagnosed definitely by ultrasound. PCOS is a known diagnosis. You cannot miss it if it is typical, but in milder cases, you may require more treatment. Low reserve ovaries may also lead to AUBs and acute endometritis, where there's a thick endometrium in the early proliferative phase with irregular junctional zone and increased vascularity may be also one of the things. Displaced IUCD may be an additional possibility. Ultrasound is the modality of choice again for that. And of course, there may be ectopics, which are not very uncommon. Ovarian malignancies may also be a cause. And of course, sometimes granulosa cell tumors. Thank you very much for that patient hearing.
Dr. Padi, you can conclude. Dr. Padi, are you here?
Am I audible, madam?
Yeah,
Am I audible?
Yeah.
Yeah. So madam has explained all the aspects of imaging very nicely. And especially, there are some questions actually. What should be the ideal endometrial thickness in premenopausal and postmenopausal women? What is the cutoff level so that we can go for further evaluation?
According to the guidelines for the postmenopausal, of course, it is 4 millimeters, as was described in Dr. Pratibha's presentation also. But when it comes to premenopausal, that is when it can be highly variable. Of course, 10 millimeters, 12 millimeters, 15 millimeters are different cutoffs given in different literature evidences. But it is very important to understand that if especially patient is under ovulation induction and the morphology of the endometrium is normal, even up to 15 to 17 millimeters, it can be considered a normal endometrium. It should match the menstruation, which is important.
So it depends on the situation.
Yeah.
It depends on the situation. That should be taken into account while taking the cutoff level. Okay, thank you so much for elaborating nicely all the imaging aspects of AUB. Thank you so much.
Thank you, ma'am. Thank you.
Thank you. Yes. So concluding the second session, we'd like to move forward with the third session, which is a very interesting case-based panel discussion. We have our experts with us. Professor Dr. Ambuja Choranur ma'am from Hyderabad. She was a retired professor at Hyderabad and visiting professor in Chennai. She's Indian representative to SAFOMS, South Asian Federation of Menopause Society, and she's been the president of Indian Menopause Society.
Okay, doctor, we are already late. I think.
Yes. But we also have our moderators. Dr. Aruna Suman, madam. She is the
No,
professor.
Professor Kavita Singh is another expert. Her
Mr.
slide is there.
Kavitas.
She's not.
Introduce her briefly. Yeah.
Yes.
Professor Kavita Singh.
Yes, Professor Kavita Singh, ma'am. She is a professor and dean of GMC Bhopal and ex-HOD of GMC Jabalpur.
Yes.
Yes.
Yeah. Now,
And our moderators for today, Dr. Aruna Suman, ma'am. She is a professor OBG in Government Medical College, Jakhtia, Telangana.
Thank you,
Joint
Dr.
Secretary of
Mannan.
OBG.
Let's
Yes.
continue.
And we'd also like to introduce Dr. Madan Kamble, who's from Akluj and the consultant OBGYN and sexual health expert and chairperson among Sexual Medicine Committee.
It's okay.
I'd like to hand over to the moderators for the further discussion. Thank you.
Can introduce panelists in one line, so that they can directly start with their case presentation.
Okay, ma'am. Yes.
Just introduce them in one line, all the panelists.
Yes. We have Dr. Anita Rajoria with us. She is the head of department and senior consultant at Hedgewar Sansthan, Government of NCT at Delhi.
Next
slide, please. Yes, we have Professor Dr. Arun Arora, sir. He is the visiting professor for ICOG and ex-HOD at Government Medical College, Udhampur, joining us from Jammu. Next slide, please. Dr. Dilip Kumar Sarangi, sir. He is the ex-director Health Services of Government of Odisha and past president of Rourkela OBGY Society. Next slide, please. We have Dr. K.S. Jayarani Kamraj, ma'am. She is Associate Secretary of World Association for Sexual Health and immediate past president of OBG Society of Southern India. Dr. Madhumati, ma'am, she is the senior consultant OBGYN from Apollo Hospitals, Hyderabad, special interest in high-risk pregnancy. Next slide, please. Dr. Maushmi Tadas, Associate Professor, Government Medical College, Nagpur, and Fellow of Indian College of Obstetrician and Gynecologist. Next slide, please.
Yes.
So I'd like to hand over to our moderators for today, Dr. Madan Kamble, sir, and Dr. Aruna Suman, ma'am. Thank you.
Thank you, Dr. Manan. My sincere thanks to Lakshmi Shrikande, ma'am, for this opportunity, and Dr. Parag Binewala, sir. Thank you so much. It's a real privilege to be in this ICOG AUB course. Starting with the panel, we'll go straight away into the discussion. I think I will get 45 minutes to discuss. We'll only discuss the practical aspects because we heard experts speaking. So let us go to the practical issues. I welcome all the panelists. Abnormal uterine bleeding, we all know it. I'm not going to go into the details. So AUB, there are the changing concepts. The old confusing terminology is no longer used, like epimenorrhea, hypermenorrhea, menorrhagia, metrorrhagia hemorrhagica, polymenorrhea, uterine hemorrhage, dysfunctional uterine bleeding is no more used. So international FIGO recommends discarding it due to the lack of clear definition and consensus on its meaning. Instead, the condition is now referred as abnormal uterine bleeding. So we know the terminology. Women's awareness on AUB. 5 in 10 women fail to report to the healthcare professionals. 49 believe that the heavy menstrual periods are just part of being a woman. 47% don't believe that they would be able to find a solution. 34% don't know that heavy periods is a medical condition. 24% didn't know how the general practice.
Aruna, please unmute. You got muted.
Okay. So actually, yes, there's a negative impact on women's quality of life and the impact of menstrual disorders. I'm not going to go into the detail of this. We have been discussing about this. There is an inconsistent clinical strategies for AUB, like age of the woman, adolescent versus perimenopausal. There is a diagnostic dilemma, medical versus surgical aspects, and other options. So this is the PALM-COEIN classification. So always we have to individualize the treatment, and individualization is a differentiated approach to choose a plan, the plan of method of treatment, taking into the account the age, the state of physical and mental health, and other factors that can affect recovery, body mass index, medical history, cardiovascular risk, thromboembolic risk, smoking, autoimmune disease, socio-economic status, patient preferences also are needed. I hand over to Dr. Madan Kamble.
Good evening, everyone. Let us start with the first case. A 15-year-old girl who had menarche at 13 years of age, having irregular cycles since menarche. she used to bleed for 9 to 14 days. Cycles were for 20 to 40 days. And heavy prolonged menstrual bleeding is there, dysmenorrhea is there, and she, she needed to take leave from the school many times. Then question arises, what about the history and examination? Is there an importance of menstrual calendar, and how to assess the menstrual blood loss? May I request Dr. Anita ma'am to highlight these issues, history and examination?
Yeah, I think our previous speakers have given us a detail what history is to be taken and what investigation Apurva very nicely told. So in this particular patient who is an adolescent, you ask her whether this heavy bleeding was preceded by any kind of amenorrhea. Because irregular cycles and prolonged cycles will often indicate anovulatory cycles. You have to take history whether she's sexually active or not. But anyways, if she's not coming up with the history, it is compulsory to get her urine pregnancy test also done. Ask her whether she bleeds a lot after getting any kind of minor injury, or she was operated and had excessive bleeding. What was her previous cycles? What was the pattern of previous cycles? How many pads she used to soak and all that. And maintaining menstrual calendar is another question which is very, very relevant, because these adolescents, although are very intelligent, but they will not be knowing what is the kind of pattern they have. So maintaining menstrual calendar becomes very, very relevant to know exact history, means what are the pattern of the cycle, what is the duration of bleeding. All these things become very important. As far as blood loss assessment is concerned, you show these graphs you should have in your OPD, and how much she is soaking in a day, what is the amount. She has to keep record of that. And these pictorial charts become very, very important in because they become an aid to ease the questioning of such adolescents.
Yes, ma'am, you are very right. As per these scoring systems, if the scores are between less than 50, it is minor bleeding, and 50 to 100 is the moderate bleeding, normal, and above 100,
Dr. Kamble, shall
we
I
can call it as
comment?
heavy menstrual.
Dr. Kamble,
Yeah.
shall I comment one?
Yes, ma'am.
Yes,
Yes, ma'am.
ma'am.
Ambuja, ma'am. Good evening.
Yeah.
Yes, ma'am.
See, taking history, as you said, it's very important. Date of menarche is still important, because if the girl attains menarche below the age of 12 years, she is likely to get ovulatory bleeding within 1 year. And if the menarche is between 13 to 14 years, she is likely to have the anovulatory bleeding for 2 or 3 years. And if the menarche is more than 14 years, it takes longer time, about 4 to 5 years. That's one point. Second point, we should know whether the heavy bleeding is in the first menstrual cycle itself, that is at menarche she had or not. It shows, because for adolescent girl, history is very important. If she starts bleeding heavily in the first menstrual cycle itself, it is definitely coagulation defects. And if it is afterwards, we should think of other anovulatory cycles. So this point, we should make a note of it.
Associated history of hypothyroidism is also very important. Any other endocrinopathies is very important to take.
Yeah.
And this is because your management will definitely be tailored according to the associated comorbidities. And history of associated dysmenorrhea also is very important, which must be
Yes.
elicited in these girls.
Okay. Thank you for those inputs, Dr. Ambuja, ma'am, and Dr. Anita Rajoria. What could be the causes of HMB in adolescent age group, Dr. Anuradhakar? Dr. Anuradhakar is there? Or you can take up, whoever is there can take up this question. What are the main...
Yes, mostly these adolescent girls are having mostly anovulatory cycles.
Okay.
This is ovulation dysfunction is one of the major cause.
Yes, sir.
Subsequent causes are hypothyroidism can be a major cause in these cases. And blood viscosity, though it's not very common, but still have a major cause in this. And one of the major thing we haven't discussed previously is hemoglobinopathy. In our part of country, sickling is a very common problem. This can also create a problem in these young girls.
Okay. Right, sir. Thank you. And Dr.
Sir,
Arun
we have
Arora.
tuberculosis in our setup.
Yes,
Yes.
that is definitely one of the cause, ma'am, because 5% of the gynec patients in 100, there can be tuberculosis. Yes, definitely. We should take a proper history of family tuberculosis, whether she's exposed or not. And definitely we have to rule out the diagnosis. And coming to the stepwise approach for investigations to clinch the clinical diagnosis. So what investigations do we do, Dr. Arun Arora?
Yes, madam. Good evening.
Good evening, sir.
Thank you, Dr. Parag and Dr. Lakshmi ma'am, for including me and the moderators. So madam, what happens basically, since this girl is just 15 and Minaki had occurred at 13, she's just 2 years post Minaki. So I'm not really worried for her, long cycles of say 20 to 40 days, but I'm still worried for heavy menstrual bleeding. That is one part. So second part is, so first I will look that like she's adolescent and that probably that age group. So I rule out pregnancy, one part, that's important. And then I will look for another, like maybe thyroid or prolactin, those things are very important. The common thing which we first go on. And then obviously, since we have the commonest is, maturation defect, basically the HPO maturation, gonadal maturation has not occurred. So I'm really not worried because she will, over a period of time, probably develop, say, normal maturation. But then I will rule out the bleeding disorders in this particular patient. That's all.
Okay, right. Thank you, sir. And Dr. Dilip
And
Sarangi, sir.
sorry, I remember one line.
Yes.
Like one of the things is PCO, which everybody is really worried like
Yes.
in this particular group, but I'm not exactly because this girl usually does not fit into PCO because we do not have anything else.
Yes.
So
Anyway, that question is there, sir. We can discuss
yeah, okay.
later. What is the girl-centered? I mean, the patient-centered management and follow-up for this girl, Dr. Dilip Sarangi, sir?
Yes, ma'am. Actually, basically in this girl, there are two parts in management. First, the bleeding causing anemia. Second, the causes of bleeding. So for this, after proper evaluation, you can check out the, anemia part can be taken care of. And subsequently, we can deal this, after hemodynamic stability, we can control active bleeding. And to control this bleeding, we can go for medications like tranexamic acid is the main thing you should use here because it's a young girl. Before giving any hormonal pills, and in hormonal pills we can go for OC pills or progestin only. I personally prefer OC progestin only in this group of patients.
Yes, okay. So later on, we'll ask Ambuja madam if we can use OC pills in this woman or not. What is her opinion and experience? Coming to adolescents PCOS, diagnosis and management in adolescent age group is very, very difficult. Dr. Jairani Kamraj, can you tell me how can we manage? If suppose we have diagnosed this to be a case of PCOS, how are we going to diagnose and manage? Dr. Jairani is there? Okay, can someone take this up, please?
Yeah, hi, Arun,
Yes,
I'll
madam.
take this up.
Madhumati, yes, please.
The thing, I mean, yeah, it is that it is not so. We shouldn't really be diagnosing PCO very quickly in not in an adolescent for the very reason that everybody spoke about the immature HPO axis. So anyway, but then you will want to rule out. I mean, in history and clinical examination, you will want to look at clinical hyperandrogenism and with a combination of irregular cycles, or if there is no clinical hyperandrogenism, you may want to rule out with biochemical tests. And I mean, using ultrasound to look into PCOM should be your last, resort. And so, if there's hyperandrogenism and it's biochemically confirmed, there are menstrual irregularities, especially if it's beyond 2 years. Also, using the formula or the time, line which Ambuja ma'am just now told us about, depending on what time, when did she start her menarche. That is how we would understand
I
whether
was
it is
asking you a question. Yes.
anovulatory or ovulatory. I mean, and if it's anovulatory cycles, and So a diagnosis of PCO is not something that we should be very lightly giving to an adolescent unless all these things have been proven. That is, you look at her clinically, biochemically, look at
So can we
irregular
do
cycles.
anti-Mullerian hormone in this patient? I mean, to rule out PCOS, will it be useful?
No, there is no role of
No role,
AMH as
no
per
role.
guidelines. Yes.
Right.
Aruna, one thing I want to tell.
Yes, ma'am.
I agree with Madhu for all her comments on PCOS. One thing everybody should be very clear: below 15 years, by doing the ultrasound, you should never diagnose the PCOS. That is abandoned. It is a rule that you should never diagnose by ultrasound, even with other modalities also. Very, very rare, because the immature hypothalamo pituitary ovarian axis produces all small follicles, so you should never diagnose.
Thank you, ma'am, for bringing up that point. So actually, we all have discussed this. So Dr. Madhumati, the question is again for you. What is the screening system in this age group for AUBC? What is your take on this?
Yeah, so I think the screening starts from the history taking itself, like everybody has enumerated till now. So couple of things. One is if she has whether it started with her very first bleeding itself, the heavy
Okay.
menstrual bleed. Then of course you will go back to her history to ask her about bleeding gums and any other, bruises, dental, treatment bleeding, epistaxis. So all that. And then, so that is one part of the thing where you will do the history. Then, when you're evaluating her, your complete blood count, your prothrombin time, APTT thrombin time, serum fibrinogen levels. These are the basic ones that you will want to do before you jump into wanting to do any other factor 10, 5, or any of those things. So, do the screening process, go through the history very carefully, and
Okay.
then, of course, if further evaluation is warranted, then of course also involve maybe your hematologist so that it could be a multidisciplinary approach.
So, okay, right. So you told about the bruising, epistaxis, frequent gum bleeding, and family history of bleeding symptoms. Yes. The same girl came with severe pallor. Her pulse rate was 110 per minute. BP is 80/60. Acute bleeding episode. And how are we going to manage this? Dr. Maushami Tadas?
Yes. Good evening, madam. Am I audible?
Yes, Dr. Maushami. And her hemoglobin now is 4 grams. So
Yes.
how do we manage her?
Yes. Now this girl, she has come with acute bleeding PV and her hemoglobin is 4 gram percent and she is hemodynamically also decompensated. She is having hypotension and tachycardia. So first and the foremost principle for managing this patient will be that we'll have to stabilize the patient. We'll have to give a proper position. Start with IV fluid. We must insert a large bore cannula. Take blood for cross matching. Start with IV fluids. And after that, we must elicit one important history is that we must rule out pregnancy and its complications. Because
Yes, that's very nice. Yes.
Girls, they are very much sexually active.
Okay.
So we must rule out the pregnancy and its complications. So
Yes,
because the
agree.
management will be entirely different if it is pregnancy and its complications. So once this has been ruled out, we must give her medications for decreasing her bleeding PV. The first line of drug will be tranexamic acid intravenously. It should be given so that her bleeding PV decreases. And once her bleeding PV decreases and the patient is stabilized, we may think of giving her blood transfusion or any other hemoglobin raising treatments depending on the situations. And we must also do the investigations for proper diagnosis of this patient.
Is there a role for estrogen injections, IV injections, estrogen? Can we give her to stop bleeding?
Shall I tell 1 minute, Taruna?
Yes, ma'am, please.
Yeah. As our friend said, she will give the tranexamic acid and all. Your case is profusely bleeding. That tranexamic acid, unless you give very high doses, it's not going to control the bleeding at all. And such an anemic patient, if you go high dose, thromboembolism is a great
Yes, ma'am.
complication.
So
And
that is
bleeding
not
will
the first
never
drug
come
of
back.
choice.
So that
Agreed.
is not the first line of treatment for
Yes,
heavy
yes.
bleeding. It is only not the OC pills also. It is only progesterones because at this
Yes.
stage it is the anovulatory bleeding that is there and hypertrophy, you can make out by abdominal ultrasound also that time. The norethisterone, that is 19-nor steroid derivatives only, is going to control the bleeding. Start with a high dose of 10 milligrams TID first for 2 days and then taper it for 21 days. Then only
Yes,
bleeding will come down in 24 to 48 hours. In the meanwhile, simultaneously stabilize the patient. But tranexamic acid, what I feel personally, it is not the first drug of
I
choice.
agree, ma'am, because it is
Yes.
thrombogenic. That
Yes.
is not the first drug of choice, and definitely there is a role for high dose of oral contraceptive according to the evidence given by ACOG. And as you said, yes, progesterones, and later on even equine estrogen IV can be given to stop the bleeding. So, ma'am,
Another thing, if I may just interrupt.
yes,
So,
yes, madam.
like ma'am said, 24-hour, I mean, when you're giving hormones, especially whether you're giving high dose COCP, like you said, or whether progesterone, but in 24 hours, if you're not seeing the bleeding controlled, then maybe you're actually dealing with a coagulation problem, or any of
So
the
one of the things,
coagulopathies.
coagulation is there, we are saying,
Yeah.
but still we have to control the bleeding.
No,
Means
no,
this
ma'am.
is the
I'm
best
just saying that the diagnosis kind of points towards maybe, we start
Yes,
thinking more about
norethisterone is the
coagulopathy.
drug of
one
choice.
more thing
Yes,
you
agree.
asked, Aruna, whether
Ma'am.
you give the IV estrogens. No, I have not given until now IV estrogen. The condition has not come, though every book mentions, because the bleeding is getting controlled with the progesterones. I feel there is no role for IV estrogens because estrogen withdrawal bleeding is always heavy and already it is a hyperestrogenic stage. Where is the role of giving estrogens for that patient? We have to control with the progesterones, not the IV estrogens.
Okay, right. So, ma'am, actually, these questions are for you. So, do we give OC pills in this young girl? Is there any controversy, or can we use low dose pills?
You are asking me, Aruna?
Yes, ma'am. This is the expert questions for you.
Yeah. OC pills can be given in the adolescent age. Previously, they were thinking that if you give OC pills, the height will be stunted, but it is proved beyond doubt and that it is not going to do any harm. If necessary, we can go for the OC pills.
Ma'am, what about malignancies in this age group? Because I have seen 3 to 4 cases at GMH. What about your experience?
Yes, malignancy is very rare. That is there. Always keep it in mind. But that is not the first line because 90% of the cases it is anovulation. If it is not controlled, and definitely malignancy is there, patient's condition, anasarca, all these things, anemia, anasarca, all this, then you have to investigate and see the patient. Yes,
Is there
it
a
can
role
be.
for hysterectomy in these young girls, ma'am? Have you done any hysterectomies?
Yes, we have done.
Yes,
Because
ma'am, even I was there with you.
yes,
But
we were
especially
there, we all
psychologically
together.
ill woman, ill girl, yes, we have done. And in one case, sarcomatous change was there, sarcomatous botryoides was there, and
That's
definitely
what
we
we
have
have
done,
seen.
if you have
But
remembered.
it is
Yes.
very rare. Unless you investigate completely and thoroughly, you cannot attribute that. Yes, we have to keep it in mind that it can be, because GMH is a ocean where you get everything.
Thank you, ma'am. And
Madam, just one line before we go to the
Now
next
it is
case.
law of the land that any hysterectomy being done less than 40 years has to be reported to state authorities.
Yes,
It is
it
a
has
rule.
to be
So
reported.
even if you are doing it for reasons
Genuine
well
cause.
known,
yes,
you
ma'am.
have to
Ambuja
see-
madam is one of the members all over India where we have to save the uterus. There is one a program saving the uterus, I think, ma'am, right? And
Yes, yes.
definitely, if there is only indication, we do the hysterectomy, not in all cases.
See, whenever we are doing below 40 years, we have a board where the oncologist and radiologist, surgeon, gynecologist all put together and then only we'll decide. Without that, we are not doing, especially for the adolescent girls.
Dr.
Aruna,
Madan?
madam, just one line before we go to the next line.
Yes, yes. Yes, sir. Arun, sir, yes.
Yeah, I just wanted to word of caution while diagnosing adolescent PCOS because the incidence is just 3 to 4% on an average, and we are always telling 20 every second girl comes with a PCOS. That is not the right diagnosis of most of the times. So there is a transient hyperandrogenemia of puberty also, That
Yes.
even that those things happen. So you have to be very careful in putting that stamp of adolescent PCO in a young girl. That's it.
Agreed, sir. Only after 2 to 3 years after she attains menarche, we can diagnose PCOS. Yes. And Dr. Madan,
Yes.
can you take up the second question, please?
Yes, ma'am. With the great input for first case, we will move on to second case. Mrs. Lakshmi, 38 years, with heavy menstrual bleeding since 2 years. It's an irregular and increased flow. There is history of passing clots. She used to have menses per 15 to 20 days, with the history of changing 7 to 10 pads per day. She is para-2 with living two issues, full-term normal deliveries. Tubectomy has been done. No history of any comorbidities. On examination, uterus is 14 week size, mobile, pharmacies are free. What are the differential diagnoses which should come into mind? Dr. Anita, ma'am?
Yeah. Sometimes these patients, they come, but still rule out pregnancy in these patients because she is still in reproductive age group, and she may be having failure of ligation. So exclude pregnancy. That is very, very important. Then you can have adenomyosis in this age group. There may be associated development of fibroid or maybe some malignancy because she's still there, and very rarely pyometra. So your differential diagnosis will now need a good relevant clinical history in detail. Do a per speculum examination, per vaginal examination, biomanual examination will tell you whether uterus is what is the exact size of the uterus, whether there is any associated adnexal pathology also. So these things become very, very important. Any associated tenderness is also important, and then you will investigate to know the exact cause of the uterine enlargement in this patient.
How do you confirm the diagnosis of adenomyosis in this case?
So ideally, transabdominal and transvaginal sonography, madam has very beautifully presented.
Yes, yes.
It will come to your rescue. It will be confirmatory. It will tell you what is the exact nature of the enlargement, whether it is fibroid or it is adenomyoma or it is a generalized adenomyosis. Everything will be visible, and especially adding on to color, Doppler will confirm your diagnosis, and you have to rule out associated adnexal pathology. That is also very, very important. So ultrasound comes to your rescue.
Dr. Sonal madam has given us very good picture on the diagnosis of adenomyosis. That was really good. And yes, this is a transvaginal ultrasound. This is MUSA, Morphological Uterus Assessment Diagnostic Protocol, according to the 2015. So this is how it looks, and let us not go deep into that because we already had it. How can, Dr. Arun sir, again for you, how can we differentiate adenomyosis with fibroid clinically as well as ultrasound wise?
Yeah, clinically, when we, see, most of the times what happens is we are always worried about the ultrasound part first. Then we are omitting those bimanual examinations. Do a bimanual examination that really gives you plenty of, plenty of times that you can make it exact diagnosis, because earlier we were making like this only. Now all these things have come and then we are trying to differentiate. Second part is because on bimanual examination, fibroid uterus are usually slightly, they are tougher uterus, what we call as a nodularities there. But in adenomyosis, they are generally overall, they are enlarged, and probably at times softer also. And when you do ultrasound, transvaginal ultrasound really tells you, because like Dr. Sonal has said, and then if you apply this MUSA, and MUSA is very good detailed classification. If you follow this line, you can really differentiate between the two parts. The only thing is about the focal adenomyosis and fibroid at times can be slightly difficult, but then you have associated findings that will be, you can make it through.
So the fibroid will have these Venetian lines, so we can make it out easily. Management of adenomyosis.
Venetian lines are typical of adenomyosis.
Yes, yes, yes.
So these are the vertical lines you will see.
Those are the Venetian lines.
Yeah.
Yes. So coming to the management of adenomyosis, can we be quick, please?
Yes.
Dr. Dilip Sarangi, sir.
Yes, actually, the management depends on few things. First, patient is severity of symptoms, desire of fertility, future fertility. And all these things will decide what we are going to do. In this particular case, fertility is not an issue. It's a fairly young lady having severe symptoms. So we should try with conservative management first. First line of treatment in this case should be OC pill.
Okay.
And if symptoms is not being relieved, then probably you can go for LNG IUCD. That will be second line of treatment. Subsequently, if it is not going out, along with that, we can put tranexamic acid during the time of menstrual cycle. If these are not fruitful, then probably you can think of other surgical maneuvers.
Now there is a role for letrozole in a
Yes,
recent
letrozole is also
studies.
there.
Yes, low
Yes.
doses of letrozole also can be given. What about the surgical management? Can someone take up the conservative surgical management and hysterectomy? What is the role of hysterectomy?
Either she can undergo adenomyomectomy. If it is a single adenomyoma, she can have adenomyomectomy. But you have to counsel the patient now that sometimes hysterectomy may also be given offered as an option, because although she is very young, she has completed a family, and ligation has already been done. And if there are multiple areas of adenomyosis, she might land up in hysterectomy also. So it depends on what you find, what is your finding on ultrasound. So many things will determine the surgical management as such.
Okay, right. So the hysterectomy is the only option, but provided she's more than 40, still the symptoms are persisting. Yes, definitely the hysterectomy has got a role. Dr. Jaira, medical management and newer treatment of fibroids and minimally invasive surgical treatment in fibroids. Dr. Jairani is not there. Can someone take up, please?
Yeah, means there are so many other options available now. You get your ultrasound diagnosis and you confirm it. Then what you can do is you can offer her uterine artery embolization also. You can give her newer treatments like GnRH or agonists are there. Elagolix is come in a big way. Then there are other, mifepristone has also got a role in decreasing the size and maybe some symptomatic relief for such patients. And studies are going on for use of letrozole also. Low dose can be used to decrease the size. It depends on the symptom with which the patient is presenting, or whether the infertility is a presenting symptom. That then of course your line of management will change. So it depends on the profile of the patient, how you are going to approach that particular case.
So there can be options for radio frequency ablation, focused ultrasound, and uterine artery embolization. Not everywhere it is available. If it is available, yes, these are the latest advancements. Now coming to the minimally invasive surgical procedures, we all know about it. Yes, yes, please.
See, whatever these medical managements have come, they are just, buying some time out of you. That's all. Because ultimately they are not going to reduce the fibroid, or, finish off the fibroid.
Yes,
So
yes.
and because the age probably is there, or maybe patient has some pain and you want to, age is less, you want to buy some time. That's it.
Or maybe
That's what.
building up of hemoglobin is required. Meanwhile, Dr. Arun, then we can use medical management.
No, sometimes when she's reaching a menopause, definitely the size of the size of the fibroid can come down, sir. You need not do hysterectomy always, I think.
No. What I basically mean is, at that point of time when you are approximately reaching menopause, you are buying time that she will go into menopause and bleeding will stop. That is what basically I mean is, you're buying time for everything.
Yes.
Aruna, one thing.
Tell me, ma'am.
Definitive
LNG
treatment for
IVS
fibroid.
is definitely going to help
Yes,
if it is
yes.
not more than 14 weeks.
Okay, yes, yes.
Also, if there is
Especially
no cavity irregularity.
nearing the menopause, for this reason, we can put LNG IUS for 10 years.
Okay.
For the fertility treatment, it's only 5 years. Here it can go up to 10 years. And by that
Provided the cavity is not irregular,
Yeah.
ma'am.
yeah, that's
If
what
there's no cavity irregularity, then she
And
should
one
be
thing
fine.
that's what
important
Madhu
is
told,
you
no?
should not
When
you
cavity
should not
is
forget
not
to do endometrial sampling
Yes.
because it that is very important. You
One has to
should
understand whatever treatment we are giving for fibroid is to control her bleeding, not to take care of her fibroid as such.
Yeah,
Okay.
fibroids may not come down. See, what we want is control of the bleeding. So endometrial
Yes, ma'am.
sampling is a must to exclude any malignancy.
yes,
But
ma'am.
once
That
once they attain menopause, the size of the fibroids will come down because they are estrogen dependent. That's
Okay.
why
That
we
is
have
up
to
to the
try Marina and then only go for other things. But only if the cavity is irregular, we cannot do anything. We have to do either hysteroscopic if it is submucous or anything, or you have to do hysterectomy. But otherwise, there are options. We have to try them and then only go for the hysterectomy.
Really sorry to interrupt, dear panelists and moderators. We have last couple of 2 to 3 minutes maximum because we want to display the post test as well for all the participants.
Okay, right. I think this is showing 6 minutes. Okay, right. We'll finish off by 4 minutes. So suppose there is a bleeding in a 40-year-old woman. The uterus is normal size. So AUBO. So suppose, yeah, we all know about this. Coming to the treatment and all.
Sampling is a must. One
Yes,
office
sampling is a must.
Yes.
So what is the role of DNC? Can we do it in younger women? And what is the indications for doing DNC? Dr. Maushami?
Yes, it can be, it has to be done. Endometrial sampling is very important in perimenopausal age group.
Do you do it in young women less than 40?
Yes, if
Yeah,
needed.
it may be done in younger women. If endometrium is thickened about 10 to 12 millimeter, it has to be done. And if the
If she's got chronic AUB and it's not, you know, you've been giving her medical management,
Not
it's
subsiding
not,
with
it's not
medical
subsiding,
management.
definitely a sampling is a must in a younger woman.
other suspicious symptoms, like because even young women can have malignancy. So if you have any doubt, any suspicion,
Yeah,
of course,
if it's
endometrial
chronic
sampling
AUB,
is a-
she must be sampled.
Okay. So we have done a scan. If the endometrium shows this, is it endometrium hyperplasia or polyp? We'll think that this is endometrial polyp. So how do we confirm the diagnosis?
It is by
Saline sonohistography.
Yes. Will
infusion
3D
sonography.
ultrasound help us?
3D
Like Sonal
ultrasound.
madam showed us
Yes,
the
SIS.
Yeah, if we have Sonal ma'am doing the ultrasound, it will.
Yes. With
Single
a good
feeding
feeding
vessel,
vessel.
you can see. Yes.
So tell me about the endometrial polyps. How are we going to manage that? Will it be malignant? How do you exclude the malignancy and all?
So
Hysteroscopic is a gold standard. So, I mean, you do a scopy, do a polypectomy, do your multiple biopsies, and then once your biopsy material, I mean, your HP, your report comes back, we, carry on with what you want to do next. Hysteroscopy is gold standard.
Perimenopausal
I don't
polyp,
see any other way of going with
perimenopausal
it.
polyp, 4% malignancy is there.
Okay.
So that's what. But do the polypectomy, do multiple
Yeah, that's
biopsies, and then
there's the end.
after
Yeah,
the histopathology report comes, we deal with it.
histopathology.
Yes.
Yeah.
Endocervical
actually-
sampling is also important. Don't do only endometrial, but endocervical sampling is also important. And pap smear, obviously, we cannot forget.
Yes. Okay.
In
So
perimenopausal.
endometrial polyps larger than 2 centimeters are often removed surgically. Smaller polyps, particularly those under 10 millimeters, may be managed conservatively with observation. And the malignancy is very rare, almost 4%. So we can do the resection of the polyps. Hysteroscopic resection can be done. So I think we are coming to AUB, endometrial hyperplasia without atypia. Can you tell me the management, please?
Put an LNG IUS and leave her alone.
Okay. Or do you want to give something orally also?
Oral progestins can also be
Can be given if she's not accepting the, LNG IUS.
Okay. So, yeah, we all know about the LNG IUS and the surgical management. Yes, what are the surgical options for atypical, without atypia, endometrial hyperplasia without atypia?
You can do the ablation. There are various methods available. You can ablate it or if you find pathologies like adenomyosis or fibroids, if you've detected, then of course uterine artery embolization in that particular area where the feeding vessel is there, you can
Okay,
do
Anita,
that.
what is the disadvantage of doing endometrial ablation in these cases?
Fertility is an issue there.
Yes, fertility.
Sampling, you can't sample it. I mean,
Okay,
But
yes.
do it after
These
you
are the 2
finish
points. Yes.
sampling.
you cannot ablate without sampling, ma'am. That goes without saying. You have to do the sampling. Your histopathology should be available. Only then you must plan these conservative, and you have to explain to that the follow up will remain the same. Patient cannot be lost for follow up. So
Okay.
these things are important.
Okay, right. So there is it is no ready-made treatment, but so we have to individualize the care we individualize the management. And okay, coming to this. So ma'am, what are there any discrepancies in PALM-COEIN classification that we can think of? Ambuja ma'am?
Really sorry, ma'am. I think this can be the last question and then a few concluding remarks. Thank you.
Yes, yes, yes.
Yes, sometimes I mean, a crossover of the things also present. Anovulatory bleeding sometimes is present in the perm and coin also. So we have to think how much it is justified, and for anything, it is the confirmation is very, very important.
Okay. So we all have to have a good knowledge, involve the interdisciplinary team or interprofessional team to evaluate the woman for the early diagnosis and management properly to give her a quality life. Thank you so much for this opportunity. Thank you, expert ma'am. Thank you, esteemed panelists. Thank you so much.
Thank you very much.
Thanks, Parag. Thanks, Lakshmi.
Thank you, Dr.
Thanks,
Lakshmi and
Sarita
Dr.
Valero,
Parag.
Dr.
Thank you for the opportunity.
Aruna Suman for the opportunity to give it. Thank you, all my colleagues here. Thank you very much.
Thank you,
My,
ma'am.
my
Thank you,
gratitude
ma'am.
to Lakshmi ma'am, Parag sir, the worthy moderator, and all my co-panelists, learned co-panelists. Thank you for making part of this wonderful panel. Thank you so much.
Thank you,
Thank you
Aruna
so
ma'am.
much for this opportunity.
Thank you.
Thank
I
you.
would like
Thank
to
you all the
thank all the
panelists.
panelists, moderators, and experts
Thank
for
you. Thank you. Now we are
having a wonderful
starting with
panel.
the post test. Please post, delegates, please pay attention to the chat box.
Can
We
you
are
tell
posting the
the
link.
website? How can we get into the questions?
No, madam.
The link.
Those who wants to have certificate, they have to click. Now the team has
We
already
are not
posted the
going to
link.
click just to
Please
see
click
what
the
is the
link.
website.
Please click the link posted in the chat box and start answering. Your time starts now.
Just to clarify, there was no pre-test. This is the only test you have to do every day. All three days you have to do 3 post-test.
Correct. Timer has already started. You have got 40 minutes. There are only 20 questions. Very, very easy questions if you have heard all the speakers very carefully. So we all will keep mute ourselves so that you don't have any distraction.
In case if anybody is unable to find the link, you can also scan your screens.
There some delegates might be having network issues. I have just personally checked the link. You can really click. It's working. The link is very much working. There was no pre-test. Please, we are telling time and again. There was no pre-test. This is the only test we are conducting.
Would just like to request all the participants to refrain from posting in the chat box so that the link can be the last message. I think we've been receiving quite a few responses that test has been done. So I would like to invite Dr. Lakshmi Srikhande ma'am to
Manan,
give.
Manan,
Yes.
just still there are 6 minutes remaining. Just
Okay.
timer is going on. We have given them 15 minutes. Yeah.
Okay, ma'am. Okay. Sure.
After their time is over, I will be giving them the answers. Yeah.
Yes.
Please stay tuned. Don't leave. We will be telling answer just now. Yeah. Seems question paper was very, very easy. Yes.
Last couple of minutes for the participants.
1 minute left. Thirty seconds. Over. Great.
I would like to invite our convener, Dr. Lakshmi Srikhande ma'am, to quickly go through the answer key and
Yes,
help us
yes.
out of our misery,
Yes,
and then
technically,
give concluding remarks.
yes. Thank you, Manan. Technical team, please show the answers. I know it was a very, very easy question paper because after 5 minutes we got the response, it's done. For first question, PALM in the FIGO system refers to, answer is B, structural causes. Second, AUBL, definitely leiomyoma. Third, the most common cause is leiomyoma again. Which of the following is a non-structural cause of AUB? Answer is D. Fifth question, the answer is C. For sixth, again, answer is C. Seventh, the answer is B. For the eighth question, the answer is C. 9, the answer is B. 10, answer is B. 11, the answer is C. 12, the answer is B. 13, answer is C. 14, it is B. For 15, the correct answer is C. For 16, again, correct answer is C. 17, correct answer is B. 18, the correct answer is C. 19 and 20, again, the correct answer is C. So friends, as we wrap up day 1 of this carefully crafted course on abnormal uterine bleeding, I want to thank each one of you for your active participation and attention. Today's session laid a strong foundation by simplifying the classification systems, diagnostic approach, and the nuances of evaluation. I hope the discussions helped reinforce clinical reasoning and clarified many commonly faced dilemmas. This is just the beginning. Tomorrow, we move from diagnosis to management strategies, covering both medical and surgical aspects in depth. I extend my heartfelt thanks to our excellent faculty and chairpersons for making today's learning so impactful. Looking forward to see you all tomorrow at 4 p.m. sharp for another enriching day. Thank you and good night. Let's meet tomorrow again at 4 p.m. Till then, bye. Good
Thank you,
night.
Lakshmi. I'm very much here.
Yes, Parag. Thank you for
On
your
behalf of the
remarks.
office bearers of ICOG, thank you each and every one of you. It was heartening to see more than 530 people at one time attending this course. Thank you, Lakshmi. Thank you, Meena. Thank you, Pratibha. And of course, the coordinators today, Manan, special appreciation to you for
Yes.
sitting. I think his debut on ICOG programs.
Yes.
So we look forward to having him again and again to help us. And Shrutika and Supriya, thank you very much. We will all see you tomorrow. Don't forget to attempt the post-test course tomorrow as well as day after tomorrow in order to receive the certificate. And thank you all the faculty. Aruna, the panel was very nice.
Yes.
I enjoyed
In 45 minutes flat, they could give so many take-home messages, Parag. I was
I know.
really flattered.
We
Thank
gave
you.
them little
Thank you.
less time, but then
Thank you, sir. Thank you, ma'am.
the
Thank you,
messages
Parag
that
sir. Thank you, Lakshmi ma'am. Thank you.
And
Thank you so
all
much.
the
excellent
speakers, they were.
panelists.
No, I appreciate Parag. All the speakers, they were within the time frame. I mean, nobody, I mean, overshot. Crisp, crystal clear, take home messages within the given time.
Yeah, that is important. That is the USP of ICOG program.
ICOG, yes.
Thank you all. Good night, and we'll see you tomorrow at 4 o'clock.
Yes.
Ciao.
Bye.
Thank you. Bye bye.